webinar. Good morning and welcome to the New York City Council hearing of the Committees on Health jointly with hospitals. At this time, can everyone please silence your cell phones? If you wish to testify today, please come up to the sergeant's desk to fill out a testimony slip, even if you are already registered online. Thank you for your cooperation. Chair, we are ready to begin.
Good morning. Good morning, everyone. I am Councilmember Narcisse, Chair of the New York City Council Committee on Hospitals. I want to thank the administration, my colleagues, and the advocate for joining us at today's hearing. The purpose of today's is to hear and receive feedback on introduction number 844 and pre-considered resolution T2023-3046, both sponsored by Councilmember Menon. As a registered nurse, I'm very aware of the healthcare struggles that impact New Yorkers. It is critical that we work to ensure that our diverse communities are equally aware and feel empowered and confident to make healthcare decisions for themselves and families. In conclusion, I look forward to hearing testimony from the administration as well as the dedicated advocates. I would also like to thank Councilmember Menon and the Health Committee and Hospital Committee staff, as well as my team for their work on this hearing. I will now turn over to Chair Schulman, Chair of the Health Committee. Thank you.
Thank you, Chair Narcisse. Good morning. I am Councilmember Lynn Schulman, Chair of the New York City Council Committee on Health. I want to thank you all for joining us at today's joint hearing with the Committee on Hospitals, chaired by my colleague, Councilmember Narcisse. We are also joined by Councilmember Menon. Today's hearing is on introduction number 844, sponsored by Councilmember Menon, a local law to amend the New York City Charter in relation to establishing an Office of Healthcare Accountability. We will also hear pre-considered resolution T2023-3046, also sponsored by Councilmember Menon, a resolution calling on the New York State Legislature to pass and the governor to sign legislation to create an independent commission to oversee hospital services pricing for the purpose of increasing access to hospital services, promoting financial stability for hospitals, and lowering healthcare costs for all New Yorkers. As I have said before, access to affordable and quality healthcare is a human right. I have dedicated my personal and professional life to healthcare advocacy. And in New York City, we are dedicated to providing all New Yorkers, no matter what their zip code is, with the necessary tools to make the most informed decisions on issues related to their health and quality of care. I want to conclude by thanking the administration, Councilmember Menon, the unions and the advocates for being here today, as well as the Health Committee staff, Committee Counsels Chris Pepe and Sarah Sucher, and Policy Analyst Minor Butt, as well as my team, Jonathan Boucher and Kevin McAleer. I will now turn the mic over to my colleague, Councilmember Menon, to give a statement on her bill.
Thank you so much, Chair Schulman and Chair Narcisse, for holding today's critical hearing regarding healthcare accountability and transparency. I'm proud to speak about my bill, Intro 844, also known as the Healthcare Accountability and Consumer Protection Act. This act would make New York City the first city in the country to create an Office of Healthcare Accountability. Our city is at a breaking point, with healthcare spending now equating to over 10% of our annual budget. For context, in 2000, the city spent $1.6 billion on health insurance for employees, dependents, and retirees. By 2017, that number rose to $6.3 billion and continued to skyrocket to an estimated $11 billion in 2023. My legislation, which is sponsored by a supermajority of council members, 43 in total, can assist the city to leverage its purchasing power to slow down spiraling healthcare costs. Price transparency works. There are myriad of examples where states were able to lower costs with transparency laws. In 2007, New Hampshire launched the website Health Cost to improve healthcare transparency. A 2019 analysis of this system's impact found that over a 5-year period, the cost of medical imaging procedures decreased by 5%. Likewise, the state of California saw a 20% reduction in joint replacement costs alone. Imagine the hundreds of millions of dollars in cost savings New York City could realize if we pass this bill. And I do want to note that some studies have pegged that cost savings at close to $2 billion. This is a major consumer protection issue, as New Yorkers often struggle to understand the associated costs of healthcare services. In New York City, a C-section can cost anywhere from $17,000 at an H&H hospital to $55,000 at Montefiore. And as seen in the graphic, and we've got a couple charts here, I hope you can see them. As seen in the graphic before you, a routine colonoscopy costs anywhere from $2,000 at one New York City hospital to $10,000 at New York Presbyterian. Families across New York City are already cost-burdened, and many have medical debt. How can we consider this a fair system when consumers are deliberately left unaware of the cost of service? The legislation is designed to increase transparency for consumers and patients compared to what exists now. My office spent literally hours navigating existing price transparency tools on various healthcare network websites and quickly learned the intent of transparency is not being abided by. For example, as you can see on the poster, there's an image of New York Presbyterian website. The website is literally broken. To even get to the transparency page, it takes 5 different pages to get in, and then once you find it, if you type in the words colonoscopy or cesarean on the page's search engine, the result is nothing. As you can see also in this poster from Maimonides, their price transparency consists of over 109,000 numerical rows, which is literally gibberish in an Excel spreadsheet. I defy anyone to actually decipher the cost of service for any of those procedures. And finally, in the example from Northwell Health, Lenox Hill Hospital, price transparency is delivered in an unreadable JSON file. Has anyone heard of a JSON file? JSON is intended, literally, I'm not joking, for data researchers and not the general public. So one can get a migraine just by trying to go on the various New York City hospital websites and trying to figure out what on earth any procedure costs. I do want to say, in closing, I'm also proud to talk about my resolution, which is being heard today, calling on the state to create an independent commission overseeing hospital service pricing to increase access to services, promote financial stability in the healthcare sector, and reduce costs for all New Yorkers. In 1996, former Governor George Pataki opted to deregulate the hospital industry for, quote, a stronger and healthier healthcare system, which I want to note the Greater New York Hospital Association opposed, with President Kenneth Rasky stating at the time, quote, this is a complete abandonment of any sense of commitment to the public good, end quote. He was right, as the entire healthcare industry is in dire need of transparency and regulation. Finally, I want to say a tremendous amount of work has gone into this bill, the drafting of the bill that we are hearing today. I want to thank drafters Sarah Sucher, Nicholas Wazowski, Nell Beekman, Julia Goldsmith-Pinkham, Minor Butt, Christopher Pepe, and Sarah Liss, and from my team, Jonathan Shutt, Brandon Jordan, and Anna Correa. Thank you so much.
I want to say thank you to Council Member Julie Menin for the work that you're doing. Thank you. And now I have to acknowledge my colleague, Baron Ayola, and Sylvina Brooks-Power. And Sylvina Brooks-Power, CM, you have a remark?
Thank you, chairs. I first would like to apologize. I'm going to have to leave for a district event early, but I did want to lend my voice in support of the legislation being heard today, recognizing the need to have greater transparency when it comes to health care and ensuring that all New Yorkers get a fair access to quality health care and are not price marked out of that. And so I would like to thank you for your leadership on this and for moving this bill forward. Thank you.
Now I would like to transfer it back to Committee Counsel to administer the oath.
Thank you. Good morning. Please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth, and to respond honestly to council member questions? Thank you. You can proceed.
Thank you. Now I would like to hear from whose testimony.
Good morning. Thank you so much, Chair Schulman and Chair Narcisse and members of the Committees on Health and on Hospitals. My name is Dr. Michelle Morse. I'm the Chief Medical Officer and Deputy Commissioner for the Center for Health Equity and Community Wellness in the New York City Health Department. On behalf of the Commissioner, thank you for the opportunity to testify today. The mission of the Health Department is to improve and protect the health of all New Yorkers. In my capacity as the agency's first Chief Medical Officer, my team is dedicated to working across the Health Department and in partnership with healthcare delivery organizations to develop and implement anti-racism policies and programs that advance health equity and accountability. We have 3 strategic priorities for this work, all of which are aligned with the recently passed Board of Health resolution declaring racism a public health crisis. The first is bridging public health and healthcare. The second, advancing the Health Department's commitment to anti-racism in public health practice and policy. And the third, which is of particular relevance for today, building institutional accountability. I'd like to take a moment to talk about this third priority and how we conceive of institutional and, moreover, healthcare systems accountability. The key to this is the need for the greater transparency into workings of our healthcare system and the ability to meet systems-wide goals such as anti-racism, equity, dignity, access, affordability, and quality. The New York City Health Department does not regulate healthcare institutions. That responsibility is held by the State Department of Health and other state agencies. However, we do use data, public dialogue, convening, and technical assistance to ensure a more accountable and equitable healthcare system. Our commitment to using data and reporting to understand our healthcare system's treatment of marginalized populations and communities, as well as our healthcare system's role in actively unentrenching inequities, extends beyond the Health Department's regular surveillance work and informs our public reporting during crises. For example, during last winter's Omicron COVID-19 surge, the agency published a report on hospitalizations that identified a very troubling trend. The COVID-19 hospitalization rate was more than 2 times greater amongst Black New Yorkers compared to white New Yorkers. We subsequently published a paper that used public health data to conduct an in-depth exploration and analysis of key factors such as working conditions and access to diagnostic services, antiviral therapies that were driving this trend. We also found that stark racial inequities in hospitalization rates were attributable to structural racism in its many manifestations, including racially segregated healthcare. We shared these findings in multiple forums to spur action, including webinars with health systems, communications to clinical leaders across the city, social media posts, and internal COVID-19 equity planning meetings. New York City is unfortunately one of the most racially segregated healthcare markets in the United States. This means that our safety net hospitals and facilities, which include New York City Health and Hospitals and a handful of independent hospitals, care for a disproportionate number of the city's Black, Indigenous, and people of color populations. Racial segregation in healthcare is in part maintained by a racialized reimbursement system, wherein those who are enrolled in Medicaid or do not have insurance are disproportionately Black and Latino. Because Medicaid reimburses at a fraction of the rate as commercial insurance, providers, including those who receive millions of dollars in tax exemptions from the government, are disincentivized from accepting patients that come from BIPOC communities, Black, Indigenous, and people of color communities. For New Yorkers, racial segregation in healthcare may mean not being able to access care at certain medical practices because your plan chose not to have that practice in their network, or because the practice chose not to accept your plan. For provider systems, racial segregation can take the form of and be reinforced by an inability to attract and subsequently provide services to an equitable number of patients who are patients of color and or are from low-income households. In our Chief Medical Officer Strategic Plan, the department highlights healthcare segregation as a key issue area for greater healthcare system accountability, and transparency. The agency is currently undertaking an approach that combines mixed methods research, community engagement, and collaborative policy development to understand the root causes of healthcare segregation in New York City and take appropriate action both at the governmental and institutional levels. Another example of the kind of accountability work that the health department has engaged in is our Coalition to End Racism in Clinical Algorithms, also known as CIRCA. Healthcare providers often use algorithms which draw upon patient data to aid in clinical decision-making. And just a side note, as a clinician myself and an internal medicine doctor who practices at Kings County, I see this all the time in my practice. There are a number of clinical algorithms currently in use that include a patient's race as a data point in a way that normalizes or assumes racial inequities in care and outcomes. Not only do these race-based algorithms entrench what we call racial essentialism, the belief that there are innate biological differences between racial groups, but their use also frequently leads to delays in diagnosis, different treatment options, and worse health outcomes amongst communities of color and patients of color. To address these challenges, the Coalition has convened members from 12 health systems across the city who have pledged to end the misuse of race and ethnicity in certain race-based clinical algorithms and to develop evaluation and patient engagement plans related to those algorithms in order to reduce racial inequities in care. We envision a healthcare system where all New Yorkers can access and receive high-quality services in settings that respect their dignity and support their flourishing. We envision a healthcare system where the care that someone receives is not dictated by how much money they have and what insurance they carry, or the color of their skin, or the language they speak, or where they live. We also envision a healthcare system that does not put undue financial burden on individuals and their communities. However, because healthcare is not formally recognized as a human right in this country, advancing this vision to the various actors that comprise our healthcare system, government regulators that hold the industry to account, health insurers that members trust to protect them from the high costs of care, providers who help people make decisions that are in the best interest of their health and financial well-being, and the members of our communities who organize and advocate for a more just, affordable, patient-centered, and high-quality health system. Patients should have easy access to accurate, user-friendly information about their out-of-pocket expenses before they incur those expenses. When we most need care for ourselves and our loved ones, we are oftentimes overwhelmed by urgency, and price shopping is not an option, or it's the last thing that we want to think about. We look forward to greater healthcare price, quality, and access transparency without placing an undue burden on individuals to shop for healthcare at a time of high stress. By placing the focus on system-level decisions rather than individuals, we focus on the system-level actors who can behave in a way so that people do not have to be weighing their health needs against often exorbitant costs of healthcare. Indeed, the most marginalized populations are often those that are most price sensitive. When faced with high costs, they may be forced to forego care. Monitoring of healthcare accountability from a systems perspective and with an emphasis on the entities that hold power over patients is much needed. We look forward to working with Council to further our commitment to healthcare transparency, accountability, and equity. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Now, should we do? We're going to do the testimony. Continue with the testimony before we come back for the question. Claire Levitt.
Good morning, Chair Schulman, Chair Narcisse, and Councilmember Menon, and members of the Committee on Hospitals and the Committee on Health. I'm Claire Levitt, Deputy Commissioner for Healthcare Strategy at the Office of Labor Relations, and with me is Dan Pollack, who's the First Deputy Commissioner at the Office of Labor Relations. Thank you for this opportunity to discuss Intro 844 and our support for the City Council's efforts to effectuate greater transparency in the healthcare system, especially as it relates to hospital pricing. While we have some concerns we'll talk about with one component of this legislation, Overall, improving transparency in healthcare pricing is a vital issue that affects all New Yorkers and demands our attention, and we thank the Council for focusing on it. As you know, the Office of Labor Relations is responsible for overseeing the healthcare benefits for New York City's 1.2 million employees, retirees, and their dependents. We work collaboratively with the Municipal Labor Committee, which represents the many unions of the municipal workforce. Our employees and retirees have what is probably the most robust premium-free health coverage in the country, costing the city about $10 billion a year, which is about 10% of the entire New York City budget. The ongoing efforts to address healthcare costs trace back to the 2014 agreement we made with the MLC to address the issue of escalating healthcare costs by working together to generate cumulative healthcare savings of at least $3.4 billion over the next 4 fiscal years, a landmark pact that has since been updated and renewed. Since then, OLR and the Municipal Labor Committee have been working diligently on finding ways to save money on healthcare expenses without impacting the quality of care. We've also worked collaboratively with our health insurance partners to identify new programs to help control the escalating costs of care. We've reported to the City Council on many occasions about these efforts. But despite our efforts, hospital costs continue to escalate, and the lack of available information on hospital pricing has been a significant barrier to achieving healthcare savings for the city. In the past 10 years, the city's hospital care costs, which represent about half of our total healthcare costs, have doubled. To just give you some anecdotal perspective on the costs, each year we experience hundreds of hospital claims that each exceed $1 million in payments, despite the significant discounts offered by our insurer. In 2016, the New York State Health Foundation reported that the variation in pricing between New York hospitals is astounding, and more significantly, it doesn't necessarily reflect the quality of care. Although our insurers are prohibited from revealing details on their contracted pricing at various hospitals to the city or to any employers, we're able to glean some significant information from our own payment data. Our most expensive hospital system costs the city about 2.5 times the cost of a health and hospitals admission, which is our public hospital system and our lowest cost hospitals. City employee utilization of the most expensive hospitals, the ones that advertise the most on television, has increased year over year, further escalating our rapidly increasing costs while hospitals push back on contractual changes that could make pricing more competitive. Despite federal transparency requirements, the city has access to very limited information about the actual costs and contracts between insurers and hospitals. Many contract provisions include confidentiality, anti-tiering language, and other restrictions to protect hospitals while leaving employers and consumers with limited information. While we note that recently enacted New York State legislation, the HEAL Act, may help to address some of this by barring most favored nation provisions and restrictions on disclosure of actual claim costs, prices, or quality in certain situations, we're not sure that it goes far enough to address all of the concerns that we have. And right now, technical corrections to the HEAL Act are moving forward through the legislature, and we look forward to seeing what happens with that. So while hospital regulation is a state and federal government responsibility, the city could support employers and consumers by collecting available public information and disseminating it in a more easily digestible way, and by working with the state to promote access to information about price and quality. In establishing any new office, we'd have to be mindful of the limitations on its authority and the cost of creating a new office and the staffing it would require. We look forward to working with the council on those details as this legislation moves forward. Despite our unequivocal support for hospital transparency, the city cannot support one aspect of this bill, which is the Office of Healthcare Accountability's oversight and audit rights of the city's healthcare costs for city employees, retirees, and dependents. OLR and the Municipal Labor Committee work effectively together in collective bargaining, where we set spending levels, we design benefits, and we select vendors for health care. And we manage this process with a great deal of scrutiny. We already audit our major insurers, Empire Blue Cross, Emblem Health, and Express Scripts, and we continuously audit a selection of hospital claims every month through the New York County Health Services Review Organization. It targets claims that should either have been denied for lack of medical necessity or for payment purposes, were coded at a lowercase severity than it was. We recover money in all those audits. So we do think that we are, with the limited amount of information that we get, we're able to accomplish a lot in those audits. The management framework that was established by the 2014 health savings agreements helps to address the collective bargaining issues that are inherent to addressing efficiency and costs in the delivery of health benefits to city employees, retirees, and their dependents. Creation of a new entity to audit OLR and the MLC in various aspects of providing health benefits could set back those efforts considerably. In response to the increasing hospital costs and the variation in hospital pricing, we also currently have a procurement for a new health plan in process that's exploring approaches that will encourage greater utilization at hospitals with more reasonable pricing. This is in the early stages of development, but demonstrates the willingness of the city and the Municipal Labor Committee to tackle the issues of hospital costs. We welcome your questions and thank you again for involving us in this important effort.
Thank you. Now we've been joined by Council Member Brewer. Thank you. And Rita Joseph. CM Joseph, thank you. This is tough because, and I have to make it clear that we're not here to regulate. We're just looking for transparency, the best way we can make sure that we get the best quality healthcare in New York City, and that's the reason we are here. I'm very concerned about safety net hospitals that serve our community and other Black and brown communities. I have no hospital in my district or public healthcare facility. The financial stability of safety net hospitals and their ability to provide quality care and safe staffing conditions are top of mind for me. I live close by 2 safety net hospitals. How can this bill help them? Anyone can answer that question?
Is that for you?
Thank you for the question, Chair Narcisse. I think it's a really important question to understand how price versus cost within hospitals happens, how the policies that drive those differences, and then how those resources support the bottom line for all hospitals, especially safety net hospitals. I don't have a great answer today for you for how this bill may or may not support the resourcing of safety net hospitals, but we can certainly look into it more closely at the health department and get back to you. I'm not sure if my colleagues at OLR want to add anything to that.
That one, I'm very interested in that. Okay. Which hospitals, if you know, which hospitals serve the most Medicaid, Medicare, and uninsured New Yorkers? How can we get more data on this to shed light on the financial disparities?
We don't actually have that information. My guess would be that Montefiore probably serves the largest number of Medicaid and Medicare patients, but I don't have I don't have that information right now. Our focus is on our employees who have extraordinary health insurance coverage and are covered at the same reimbursement no matter what hospital they go to, which actually probably encourages them to use the more expensive hospitals without even really knowing that they're the more expensive hospitals. But I think people are affected by the advertising that they see and by and probably avoid the safety net hospitals.
Just one more piece I'll add to that as well is that we also know that half of all Medicaid beneficiaries in the state of New York are here in New York City, so we do have a very large proportion of the state's Medicaid beneficiaries.
What are the different type of community benefits do hospital provide as required to receive federal tax exemption?
Chair Narcisse, can you restate the question, please?
What are the type of the community benefit do hospital provide as required to receive federal tax exemption?
We can certainly follow up with something more in depth. We didn't prepare any specifics on that today. However, the health department does support and work with many hospitals across the city on their community health needs assessments. In fact, most of those hospital systems use the data from the health department to inform their community health needs assessments and the plans that they develop to meet needs of communities. And as you stated, Chair Narcisse, that is a federal requirement that they report on that as a part of their tax exemption process. But we can follow up with additional details after the hearing if you have other specific questions for us.
I want to make sure we are centering the most marginalized and making good policies. That's the reason that we're here today. I understand it's difficult. Some folks say, no, we should not even touch it because it is a federal, yes, we understand that part, but we are looking for transparency. That's why I'm asking those questions.
Yeah, we're not suggesting in any way that we should not be touching it.
No, I'm saying not you per se.
Fully supportive of the idea of transparency. Transparency is the first step to any of the initiatives that we want to talk about in terms of monitoring and effectuating healthcare savings.
So, like I was saying, I want to make sure we're centering the most marginalized and making good policies. How does denial of medically necessary care for care by insurance companies impact costs to the patients in the hospital? You want me to repeat it?
Yeah, please.
Okay. Since I want to make sure that we centering the most marginalized and making good policies, how does denial of medically necessary care by insurance companies impact costs to the patient and hospitals?
The denial of medically necessary care? There is some limited denial of medically necessary care that we see in the employee population, but it's not denial. It's not so much denial of care as it is moving care to more appropriate venues. So, for example, I notice that there's a lot of discussion there about colonoscopy outpatient costs. Colonoscopies routinely should not even be done in the hospital. They should be done in ambulatory surgery facilities or doctor's offices unless a patient has extraordinary needs and needs to be in the hospital. That's the kind of so-called denial we see in terms of medically necessary care, that a recommendation will be made. This procedure doesn't need to be done in the hospital. It needs to be done in an ambulatory surgery facility where you're going to get equal, if not greater, reimbursement for it.
But one of the things that I have heard too many, that the reimbursement for hospital is greater than the outpatient, and that's the reason that most of the patients end up in the ER in some ways.
That that reimbursement in the hospital, actually, our reimbursement for both hospital and hospital outpatient is really almost equivalent. We have a $300 copay for hospital inpatient stay. We have for outpatient, we have a $200 maximum copay. So we're really not incentivizing people to go to the hospitals. You know, the employee situation really is very different than what we're talking about with a lot of our marginalized groups, because we have great coverage, and you know, and it's a very different situation when people are making choices between all the hospitals without the need to look at what the costs are, because the costs for them are the same.
In Intro 844, that's what we're talking about mostly
Yes.
today. What is your position on Intro 844, which would establish an Office of Healthcare Accountability, you already know that, to audit city expenditure on employees-related healthcare costs and make recommendations on how to lower this cost, right?
Yes, thank you, Chair Narcisse. So, you know, we are broadly supportive of the effort to establish greater healthcare transparency. You know, our one concern with the legislation is the aspect about auditing city employee health costs and having this office involved in that effort. You know, we negotiate city employee health costs with the Municipal Labor Committee. We work with them. We do our own audits, and you know, we really feel that that is a matter that's best left for that process between OLR and the Municipal Labor Committee. But overall, we are greatly supportive of the effort to improve price transparency, and we look forward to working with the council more on the details of that.
We also think that it can help inform our work. All this information on transparency will very much help inform what we're negotiating with the Municipal Labor Committee, what we're negotiating with hospitals. We are, to some extent, despite the fact that we have access to a great deal of information, we're still somewhat in the blind about hospital pricing and insurer pricing. And we hear from both the hospitals and the insurers that the information is confidential, and while we have our own data, we don't know all the things that drive that data.
I'm going to ask that to the doctor again. What are the primary factors that contribute to healthcare costs, from your opinion, of as a practitioner?
Thanks, Chair Narcisse. And just to follow up on my colleagues at OLR, the Health Department is also supportive of the intent of this bill, and we believe that transparency about hospital prices and other healthcare prices as well is critical to advance equity and improve access. And we also believe, as our colleagues at OLR, that making that data much more legible for the public is certainly consistent with those values around transparency. From my clinical experience as a physician, I think, and as a member of the health department or a staff member at the health department, certainly a big part of the challenge with costs in healthcare is that we invest more in treatment than in prevention. And from the health department perspective, certainly investing more in prevention activities and services would both improve the health of New York City overall, it would improve population health equity, and it would certainly reduce some of the healthcare costs that we see growing. I'll leave it at that. Thank you for the question.
So you're the only physician there, right? What health outcomes has your community experienced as a result of the increase in healthcare costs? And have you received any feedback from the community? That's still you. You, the physician. The physician. Yes.
Just to clarify, the question is, what feedback have we gotten from community members about their concerns about the costs of healthcare? We can certainly follow up with more details on that. I will say that particularly in the era of COVID, what we have heard a lot is that free vaccines and free treatment, for example, have been tremendous in terms of access to care. To my knowledge, we have not done any specific surveys recently about changes in costs since COVID, but we can follow up with you about our community health survey data, which does ask several questions about the costs of healthcare and how healthcare costs might be barriers to access to treatment. I wasn't prepared with that information from that survey today, but we can send that to you in follow-up.
In other words, you have that survey?
Correct.
Okay, thank you. I'm gonna pass it on to my colleagues. Oh, I have some more colleagues. I've been joined by Councilmember Yeager, Moya is online, and who else I'm missing? Everybody? Yep. Everybody good? Okay. Brewer. I did already. Okay. So I'm passing it on to my colleague.
Thank you very much, Chair Narcisse. So the first question I want to ask is, so Dr. Morse, my understanding is that the federal government requires some information related to healthcare costs for patients. Can you speak to H&H's, I know you're DOHMH, to H&H's disclosure of that required information? And is that anything that's shared with DOHMH?
Thank you for the question, Chair Shulman. I cannot comment on H&H's behalf on this question, but I'm sure that they could respond in follow-up to the hearing about how they're meeting the transparency requirements at the federal level.
You had mentioned earlier about the community health assessments that you have, and so does DOHMH audit those to see who's complying and who's not?
The health department is involved in the community health needs assessment process. In terms of a formal audit process, I don't have that information with me today, but we can certainly follow up with you.
Because I think that if we're auditing them to see what they give back to the community, which they're required to do, I think that would be helpful to this effort.
The state does do that.
Okay. How much in total, so this is for OLR, how much in total did health benefits for city employees and retirees cost last year?
Over $10 billion.
How much has it grown in the last 5 to 10 years?
It has, let's see, it has, I know on the hospital rates, it has doubled in the past 10 years. I'm not sure if I have the combined rates. We can get that.
It's grown substantially.
It has grown substantially.
acknowledge that.
We know that the hospital costs have doubled, and everything is much higher, including medical and prescription drugs.
From your perspective, what's driving those increases?
Hospital is a very big driver of it. Prescription drugs are another big driver. One of the things we're focused on now is our utilization at the highest cost hospitals and a growing utilization at the highest cost hospitals.
It's estimated that there's $2 billion in savings available if the city's health plan were to pay hospitals the same rate as Medicare. How are you going to realize those savings?
I think that it's aspirational to think that we could get Medicare rates for commercial health insurance. We spend about about $5 billion of the $10 billion on hospital costs. So $2 billion, saving $2 billion would be saving 40% of our overall hospital costs. It's certainly aspirational, but the first step to that is absolutely transparency and knowing what we're paying and what we're paying where. I think it'll take us a while to get to that $2 billion in savings, maybe some fundamental changes in the way that we reimburse healthcare. But we think transparency is the place to begin.
I know the bill covers this, which is great, but what I'm going to ask you is, does the city now assess the price variation among hospitals that its members use?
We do. We don't have access to the actual, other than what you see on, what you see on the websites. We don't know what the insurers are actually charged by the various hospitals. But what we are able to do is collect all our own claims data so that we know what we're paying on average at each hospital for our employees and their dependents and retirees.
So how does the city leverage its buying power? Because obviously we have a lot of employees, a lot of city workers, a lot of retirees. So how does the city leverage that with the hospitals?
These are great questions. Thank you, Chair Schulman. We have leveraged it to get the best deals that we can from our insurers. We have tried to leverage it with individual hospitals. Last year, we reached out to every hospital system in the city, other than H&H, which obviously we have a good relationship with. We reached out to every hospital system jointly with the Municipal Labor Committee and asked them to do better on the pricing for the city employees. 2 of the large hospital systems refused to meet with us. The other 3 met with us and said, if you send us more patients, we'll give you better pricing. And that, despite the leverage we have of covering, probably 10 to 15% of the city's population, we ran into an unwillingness on the part of the hospitals to negotiate. We think through our insurers that we're getting the best rates that we can now, but what we're looking at a procurement right now in which we hope to leverage more of the size of our population and the influence of our population, but also help to direct people to what we think are the lower cost but still quality hospitals. And we're currently in the midst of that procurement.
So I'm going to mention a piece of possible leverage that a lot of people don't know about. So Health and Hospitals has affiliation agreements with a lot of these private hospitals. And what that means is that their residents and interns can work and get experience in the city hospitals, and then they go back to the private hospitals. They get paid a substantial hundreds of millions of dollars to do that, and maybe that's a way to leverage some of this with them. So I wanted to just put that out there. I know H&H is not here to answer that.
Yeah, it's an interesting concept.
What is the city's long-term strategy for addressing hospital prices as the root cause of ballooning healthcare costs?
Well, what we're trying to do short-term, which has been our long-term strategy for many, many years now, is look at how we can help direct people using preferred or non-preferred hospitals, incentives. We're looking, we're asking each of the insurers that are bidding on our new health plan to help us design programs that can help reduce hospital costs and overall healthcare costs.
So is it safe to say that there are a number of city offices and employees responsible for analyzing hospital and healthcare prices paid, which is what this Office of Accountability would address?
We work with a team of people at OLR which includes people from OMB as well as OLR. And we have consultants, our actuarial consultants from Milliman that help lead this. They're the ones that collect the data and help us analyze the data that we have. So we do have a great deal of information about where our employees are going and what it's costing us, but again, it's aggregate data. It's average data from our healthcare claims.
And I'd also add that the Municipal Labor Committee also has staff devoted to this effort, and as well as their own actuarial consultants who work with ours.
Does the city have a process to determine the average price per procedure at major hospital systems?
We do. We do have that information.
And how is that utilized?
Well, at this point, we haven't been able to really actualize anything actionable from that data. We're hoping to do that in conjunction with this new procurement that we're doing.
Okay, I'm now going to turn it over to Councilmember Menon for questions.
Thank you so much, Chair Schulman. First of all, I really want to thank you for your testimony today on my bill, because I appreciate the administration's support of price transparency in the bill, and I am confident, based on all of the research we've done and looking at what other states have done, that we will once and for all lower prices through this transparency measure. So one of the things you mentioned in response to Councilmember Schulman that I found really shocking is that 2 hospitals would not meet with the city. And as you point out, the city is 10 to 15% of the city's population is actually in these hospital systems. So the hospitals literally have the city over a barrel, and it's unconscionable that they're not meeting with you. And that is, again, why this bill is so important, because it will finally allow the city to harness its purchasing power to demand that these hospitals lower their prices. So I have a couple questions. Last month, you told the council at the Committee Civil Service and Labor that you had issued an RFP. Could you talk a little bit about that? What's the status of that?
Yes, thank you, Councilmember Menon. We have issued the RFP. We have received some initial bids, and we have gone out to all of the bidders with additional questions based on the initial proposals that they've made. And we are trying to get more detailed information than we got in the first round of information. So we're really sort of right in the middle of the process of this. We hope that the process could conclude sometime by the end of March, mid-April, something along those lines.
And currently, right now, how many employees across OLR and other city divisions do you have that are working on healthcare costs?
We probably have, between OLR and OMB, we probably have a dozen people or so that are working on various aspects of healthcare costs. But we also have our consultants at Milliman, where they have a very robust team of actuaries and other research analysts that do a lot of the data analysis.
Okay, and I see my time is up. If I can just ask one last question. If this legislation is enacted, how will that allow you to drive costs down?
Well, as I said before, Councilmember Menon, I think that transparency is the first step to being able to negotiate better healthcare pricing. We don't know what we don't know, and this will definitely help inform us about what the costs are at the various hospitals.
Great, thank you.
Thank you. I want to Yes, my council member Charles Barron for a question.
Thank you very much. This is an incredible hearing. You know, I've been at this for a long time, and I just find it first of all, this is a no-brainer. I don't see how anyone can be against this bill. But for you to have a better relationship with the greedy insurance companies than you do the hospitals, and for workers, when they come to negotiate their wages, they use healthcare as manipulated so that they have to now say, okay, well, if we give you this raise, then you can't get this healthcare, or if you get this healthcare, then the raise has to be lower. That's a game they've been playing for a long time. And it's time that we just tell the truth of what's going on with healthcare. You know, I know some of you may have problems with socialism, but capitalism has gone mad. And in the healthcare industry is a real indication of that. You know, how do you have, on a federal level, we have some of our members of the New York Congressional Committee or representatives voting with Republicans to condemn socialism, and in that same bill, they say we also are against socialist types of programs like Medicare and Social Security. So they voted against socialism in a bill that also was against Medicare and Social Security. To me, that's incredible. I want to see where you stand on that. Also, when I look at the state budget, I was in the state assembly when Andrew Cuomo was governor. He didn't cut Medicaid, he had savings. That's the new word for cuts. So anytime, please let me finish.
Sure.
Anytime that you hear the word savings, they're cutting. They're cutting at a time where we have surplus in budgets. And then on the city level, your mayor is cutting your agencies, 3% across the board. How do you feel about that? That we're talking about better service, and in a state that has a $224 billion budget, and city that has a $102.7 billion budget, you cut in social service, including health care. So when you come, show us the money. Show us the money. The rhetoric we're tired of. Of course we're going to support this bill. It's going to go through. You needed transparency to find out after all of these years that the overcost in hospitals, so you need a transparency, like oh, we need to find out what's going on in the hospitals. You need that now, after all of these years? You didn't know the price gouging that was happening in the hospitals, so we have to have a bill for transparency and celebrate that, and you sitting there like, can't wait till the bill comes out so we can find out what's going on. Come on, y'all need to stop it. We need to stop it and deal with our people in a real way. We are dying. We are dying in our communities. People have gone bankrupt trying to deal with health care costs. And the cost goes up, but the quality of care doesn't. That's a problem. So I want you to address some of that, not this typical stuff we have at hearings, and then you say, oh, I don't have that, I have to get back to you. Well, then when did you find out you were having this hearing? For you to have to get back to us on so much stuff when you knew about this hearing for a while is a problem. It's a real problem. So let's cut the nonsense. Let's cut it to the chase and tell the people what's really going on. Profit over people. Healthcare is a multi-billion-dollar profit. The insurance companies are laughing their way to the bank. And we sitting here talking about transparency, and you got a better relationship with the bankers, the profiteers, than you even have with the hospitals. That's a real problem. So if you can address some of that, like your colleagues in the federal government supporting a resolution that is challenging and may cut to health care, your mayor who's cutting some money from your agencies, how do you really address that?
So I'll just start, council member, thank you. Just to speak to OLR's role, the Office of Labor Relations, which is, on city employee health costs, we are not looking to make cuts to health insurance. We work with the Municipal Labor Committee, with the unions every day to try to find ways to find savings, yes, but to do so while maintaining the same high quality that we want to deliver. That's been our goal.
I got to go, but that's a bunch of rhetoric. There are cuts. I look at the budget, there are cuts. So don't come here saying you're trying to find savings. Savings are cuts. Savings are cuts. So tell the truth. And you said you're not supportive of a part of the bill when it comes to the negotiations with labor. Labor's supportive of the bill, but you're not. So I'm not sure if everything's so rosy with your relationship with labor, but let's just tell the truth. Savings are cuts.
Respectfully, council member, I don't agree that in all cases that's true.
Savings are cuts.
You done? Thank you, council member.
Yes, thank you.
And now we have question from council member Ayala.
Thank you, chairs. I appreciate it. My questions are for OLR. Ms. Levitt, you in your testimony, in your second paragraph, you said that while you have some concerns about the legislation, what is your main concern about the legislation?
Thank you for the question, Council Member. The main concern that we talked about is simply whether there will be oversight from this Office of Healthcare Accountability over what is now done in collaboration and collective bargaining between the unions and the city. We don't think that that's appropriate. We do audit right now. We audit our insurers, we audit hospital claims, and we set benefit design and vendor relationships working with the unions. So I do believe that that would sort of usurp the role that we have. We have no problem with the idea of, sharing some of the information that we have with this Office of Healthcare Accountability, and we want to work with you towards transparency. That was the only aspect of the bill that we had any problem with.
And I also did hear you say, and it's not part of your testimony, but you did say that you were concerned about the scope of the commission and what they would have input over and what their range of input would be, because that's a concern of mine as well.
Are you talking about, I'm sorry, I'm not
The
sure.
commission, the commission
The Office of Healthcare Accountability and what they would have
Right.
oversight over. Only as it pertains to, what gets collectively bargained and what we work on.
Right.
With the Municipal Labor Committee. That's our only concern.
Right, for our active employees and our retirees.
That's right.
Correct.
That's
So
right.
just in closing, it seems, and you really do identify it in your testimony, that there is the HEAL Act, and there was improvements to the HEAL Act.
Yes.
There is collective bargaining that goes on already. And coming from a background of working for a safety net hospital that gives, to this day, high-quality health care at a low cost, I know how difficult it can be, but it does get done. And what I worry about mostly is if savings are cuts, then why are we layering another commission on top, which will need funding, which will need employees, and will need people to collect the data that's already being collected. So thank you so much for your testimony.
Our philosophy has always been that savings are not necessarily cuts.
I'm saying, let's say that's correct. Let's say it's correct. Why are we creating more commissions to do what's already being done on a state level and through collective bargaining? That's my point. I'm not saying that savings are cuts. I'm saying if that is correct. This is already being done, and everybody wants price transparency. No one could say no to that. Everybody wants good health care at low cost. but I think that there are measures in place already that, that wouldn't need a new commission to be put forth because of the concerns that you mentioned and the concerns that I have for its scope. The scope of that commission is not identified.
The concerns that we have are related only to the employee programs that OLR administers. I think that this Office of Healthcare Accountability will address the issues on a citywide basis, where the problems, many of the problems that Dr. Morris talked about the inequities, are much more pronounced, where people don't have access to the kinds of excellent healthcare coverage that our employees have. So that I do think that transparency and empowering consumers and other employers with information is an important project.
Thank you.
Thank you. We have been joined by Councilmember Velasquez online and Councilmember Felice here with us. Are cost negotiation processing identical among all health insurance companies by any chance? Anyone can answer that question for me?
I'm sorry.
Are cost negotiations processes identical among all health insurance companies?
It's a great question. Thank you, Chair Narcisse. We don't know. And that it's part of what I'm saying, that we don't know what we don't know. I think that different insurance companies have different approaches to negotiations with hospitals. They all have their different focuses, and the rates vary from insurer to insurer a great deal. It's not just variation hospital to hospital, but insurer to insurer, and then procedure by procedure. And so, my sense is that when one insurer negotiates a great rate for some procedure, they pay for it on some other procedure where they're paying too much. So there is no consistency. And again, we don't know what we don't know, and transparency will help us find out about that.
From my understanding, there's a wide differences in reimbursement through insurance company, which I think is outrageous. But that's another conversation. Well, it should be part of this conversation because we want to know. How often do prices change on procedure at hospitals? What drives these changes in prices? And the next, do costs to patient ever decrease?
What drives the changes is negotiations between the hospitals and the insurers. We don't always know about it. We have over the past few years gotten more information from our insurers than we ever have before, and we have gotten in the middle of some of the negotiations between the hospitals and the providers and our insurers, but they drive the pricing. We don't, and again, there may be cost increases that are happening that we don't even know about until we see an uptick in our data.
Okay, and do costs ever decrease for patients?
I think occasionally there are procedures that become more routine and costs can go down, but in general, prices keep rising and rising year over year. I think that our employees, again, have really excellent benefits so that their costs really haven't gone up. But I think that they're protected from the reality of the differences between different hospital systems.
All right, so now, Chair Shulman, any questions?
No.
Now, thank you for being here. Thank you for your
You're
time.
very welcome. Happy to be here supporting this.
Thank you.
Thank you.
If admin can stay for a little longer because we're gonna have public testimony, that would be nice. If they have someone to stay here to listen to the public testimonies, if possible. Okay, thank you, appreciate it.
All right. All right, thank you. We are now going to be moving on to public testimony. In general, we will be hearing from folks in the room first, followed by folks who are logged in, our virtual panelists. And just a note before we call the first panel that if you're submitting written testimony, you can do so up to 72 hours after this hearing. And that's at council.nyc.gov/testify. We're first going to hear from David Rich.
Good morning. Can you hear me? Great. Good morning. Thank you so much for having me. My name is David Rich, and I'm with the Greater New York Hospital Association. Our members include all New York City hospitals, both public and private. I hope today to clear up some serious misconceptions about hospitals, and I will explain why we believe Intro 844 oversteps the city's jurisdiction by reinterpreting federal regulations and then judging hospitals according to its own interpretation of federal rules. There's been more heat than light surrounding this bill, and the rhetoric has been unfortunate. As you know, hospitals save lives 24/7, 365. They're huge economic engines for New York City. They are trusted and deemed essential by your constituents who rate them very highly in public opinion polls. Accusations of greedy hospitals making enormous profits are unwarranted and couldn't be further from the truth. Two highly respected national firms have found that in 2022 was the worst financial year for hospitals since the start of the COVID-19 pandemic, and that over the last 3 years, not-for-profit hospitals have endured multiple disruptions, first from the coronavirus pandemic, and now by labor shortages. Labor costs are exploding due to shortages and the need to increase salaries to retain workers. In my written testimony, I detail the enormous new costs associated with recent nursing union settlements. Many of you supported the workers in their demands for higher wages, which is totally understandable. However, the bill for these settlements will now come due. We would strongly support City Council members providing grants to already financially distressed hospitals to help them afford the settlements that you supported. The rhetoric surrounding the bill also ignores the reality of hospital finances. Concentrating on rates negotiated between insurers and hospitals alone does not tell the whole story. If you'll bear with me for a moment, because this gets a little bit complicated. More than 75% of hospital payments in New York City, 75%, are set by the federal and state governments through Medicare and Medicaid. They're not charged by hospitals, they're set by the government. and hospitals lose money on every single Medicare and Medicaid patient because of these government-set rates. Medicare covers only 85% of costs. Medicaid covers only 61%. No enterprise can survive with such underpayment for their services unless they can negotiate higher payments either from private insurers or they're subsidized by the state. This is why we have 12 not-for-profit hospitals in the city that need to be subsidized by the state just to keep their lights on, precisely because their Medicaid and Medicare share of patients is higher than the city average. These hospitals have too few privately insured patients to be able to negotiate higher reimbursement rates to offset their Medicaid and Medicare losses, and some of these hospitals are in the districts or near the districts that you represent. Likewise, New York City Health and Hospitals, the system with the highest proportion of Medicaid-eligible patients, needs extra support that is uniquely available to public hospitals through intergovernmental transfers and city subsidies. Other hospitals with a higher proportion of privately insured patients can try to make up for Medicare and Medicaid losses by negotiating higher reimbursement rates with insurers. It is important to note that these rates are negotiated and agreed upon by insurance companies. Rates are not a one-way street, somehow dictated by hospitals. And huge national for-profit insurance companies have the leverage in New York's competitive hospital marketplace, where 8 hospital systems and many freestanding hospitals compete vigorously for patients. That is why there is price variation among hospitals. Each price is negotiated separately between hospitals and insurers. While these hospitals have a higher proportion of commercially insured patients than the state-subsidized hospitals do, they nevertheless provide care to tens of thousands of Medicaid-eligible patients annually. Some are the biggest providers of inpatient care to Medicaid-eligible patients in the entire state. They therefore suffer huge losses that must be made up somewhere. Proponents of the bill have claimed that if New York City paid hospitals what Medicare pays hospitals, the city would save $2 billion. I don't know the veracity of the statement. However, I do know that if all commercial hospital rates were reduced to Medicare payment rates, 100% of our hospitals would need subsidies to survive, not just the 12 that are currently receiving them. And they would certainly not be able to afford the labor settlements they have recently agreed to. Specific concerns we have about the bill include CMS just reported 2 weeks ago. CMS is the federal agency responsible for the rule, wrote the rule, interprets the rule, and also enforces the rule. They reported 2 weeks ago that 82% of hospitals are complying with at least one of the 2 prongs in the federal transparency rule, while 70% are compliant with both. CMS has announced that they will take more aggressive measures to ensure compliance, and already they have increased their penalties to $2 million per year per hospital for not complying with the rule. We checked the websites of every hospital in New York City and found that they all had published price transparency files on their websites and/or taken the rules option of providing a cost estimator for consumers. What I have here is one of our independent hospitals, a hospital that's very high in Medicaid and Medicare in the Bronx. This is an eighth of what they were required to put online. I didn't want to print out 8,000 pages, but the first prong of the rule says that you have to put online in a machine-readable format every single price that you have negotiated with every single insurer. One of our hospitals has 1,198 separate insurers or different products within insurers that they have had to negotiate prices for, and that is what is on their website. Despite CMS reporting 70% compliance, the sponsor of the bill stated on Tuesday that only 6% of hospitals are complying. An outside group reported that only 25% comply, while others have reported that 60% do. Why this discrepancy between the CMS figure of 70% compliance and these estimates? It's because groups have taken it upon themselves to interpret CMS's extremely complex rule differently from how CMS interprets it and enforces it. We fear this is exactly what the new city office would do. The only entity that we believe should determine if hospitals are compliant with CMS's rule is CMS. It's their rule, their requirement, and their enforcement responsibility, and they are now increasing enforcement. Second, the bill requires the new office to report on hospital compliance with the IRS's requirements on community benefits, a federal requirement. The IRS specifically includes in its requirements a variety of community benefits. However, outside groups supporting this bill have financed studies that have completely rewritten the IRS's definition of community benefits. They've left out whole categories of community benefits recognized by the IRS. Based on these unauthorized definitions, these groups have deemed hospitals deficient in the community benefits that they provide. Given the biases of the outside proponents of this bill, we fear that this is what the new city office will do as well. This also is something that the IRS should determine compliance about regarding its own rules and its own definitions, and not a new city office. Third, the bill focuses almost exclusively on our community hospitals. It virtually ignores behemoth national for-profit health insurance companies that make enormous profits in New York's healthcare economy and ship those profits out of New York to their parent organizations and shareholders. It's ludicrous to believe that if somehow hospital payment rates were reduced, these plans would share savings with consumers. They would merely add to their profits. The bill also completely ignores skyrocketing pharmaceutical costs, medical device costs, other supply costs, and increasing costs of labor. Hospitals are part of the healthcare economy. They also have to purchase skyrocketing pharmaceutical prices. They also have to purchase a whole variety of things that are within the healthcare economy. All that goes into a hospital price includes all of those things as well. So you can't just say hospital prices are the following. You have to also understand that they are buying, and in that same healthcare economy, where all costs are going up. Given this, we believe the bill is inappropriate and duplicative of federal regulations. I'd be happy to answer any questions you may have. Thank you so much.
Thank you for your time, and I'm gonna pass it to my colleague, Julie Menon.
Thank you so much, Chair Narcisse. So in your testimony, you talk about adherence to the federal rule. I wish I could say that these hospitals had adhered to the federal rule. You mentioned that you've looked at every single New York City hospital website. I don't understand how, with a straight face, you can actually say that they're complying. We spent hours, my team and I, hours and hours and hours on every New York City hospital website. I didn't want to bring too many easels. I just brought a few. Maimonides over there. You have to go 5 pages to find this Excel spreadsheet. The Excel spreadsheet is 109,000 rows of numerical gibberish.
Yes.
How can anyone figure out what the price is with 109,000 rows?
So that is one of the prongs of the federal rule. One prong is that they have to do this and that. They have to have every single service by every single payer, every negotiated rate. These are not what they charge. These are what they've negotiated with every payer. So that is half of the rule, and it's a huge undertaking to do that. That is partly so that different insurers can use their different algorithms to actually look through all of those prices. That's why it's required to be a machine-readable file. That is not something that's really meant for the average consumer. The other half of the rule is what's meant for the average consumer, which is either posting 300 what they call shoppable services and those prices, or have a cost estimator tool, one of the two. And most of our hospitals have opted for the cost estimator tool. I should mention that starting January 1st, insurers are required to have that as well. And that will have much more information because it won't just be hospitals, it'll be all different types of providers.
This is exactly why we need this bill, because any consumer, and I say this as a former commissioner of consumer affairs for the city, any consumer cannot make heads or tails of this data, whether it's 109,000 rows, whether it's Lenox Hill having a file in JSON, which only data scientists can read, whether it's New York Presbyterian. where you literally can't search up colonoscopy, appendectomy, cesarean. You can't get any information. And I also strongly refute what you say about CMS assessing penalties. To date, CMS has only assessed penalties against 2 hospitals in Georgia. So they're not, the federal government is not assessing the penalties. This is why, again, the city needs to act. We're not looking to regulate hospitals. We're looking simply to have price transparency for consumers. So that is the intent of the bill, and that's why it's sorely needed.
All right, you done? You finished?
Yes, thank you.
Okay, thank you. And I'm going to pass it on. Before I pass it on to Chair Schulman, are cost negotiation process identical with all healthcare insurance companies?
They aren't. They really do vary by each insurance company and each hospital. It all depends on what those negotiations are like. Different insurers may want to make sure, because their enrollees are clamoring to make sure that a certain hospital is in their network, in which case they may pay a little bit higher to make sure that happens. But they also might decide they don't need to pay higher rates at other hospitals that they feel not that many of their enrollees go to. The other issue between hospitals is you have hospitals that have certain services and much more complicated services that other hospitals don't have. So for instance, you have a hospital that might have burn units like, Jacobi or New York Presbyterian. They have ongoing costs all the time to keep that burn unit open, even when there are not necessarily that many burn patients, waiting for the day when unfortunately they might have a lot of them due to a fire in the area or whatever the case might be. So they're going to have higher costs than another hospital that doesn't have that. Same with hospitals that have transplant units. Same with hospitals that are trauma centers versus hospitals that are non-trauma centers. So they have a lot higher costs that need to be covered than certain community hospitals might have. I'm sure you've all had the situation where you've had a loved one or yourself where you went to the nearest hospital but then needed to be transferred to one that had other services and more complicated and sophisticated services, because those tend to be concentrated in certain hospitals. So in negotiations, those things are taken into account as well. Some of that is why there's price variation, but there are a whole lot of reasons why there might be a difference between what one insurer negotiated with a hospital versus what another did, or one insurer negotiated with this hospital versus what they've negotiated with another.
Do you believe that in your opinion, do you think that the Intro 844 gonna create a more problem than solving a problem?
My concern about it is we don't know what definitions they're going to use. As I said in my testimony, CMS wrote this rule, they interpret the rule. They reported 2 weeks ago that 70% of hospitals were compliant nationwide, yet other groups say it's 6%. Well, what are they basing that on? CMS, the federal government, is the one that wrote the rule and interprets it and enforces it, whereas we just don't know what rules are going to be used by this new city office. And it's the same with the community benefits. One of the unions who supports the bill had financed a study of community benefits. And in that study, they left out whole portions of community benefits that are recognized by the IRS, including education of nurses and doctors and other allied health professionals, including losses from Medicaid, which Dr. Morse talked about very eloquently earlier, about how little Medicaid pays on behalf of their patients, really fostering a system of institutionalized inequality because of how little they pay for low-income patients. So that's really the concern that we have. If they were going to use exactly what, the criteria that CMS is using, if they were going to use what the IRS is using, I think we'd have a lot less concern about it. But given that we keep hearing these different numbers thrown around, and then the actual authority behind the rule gives a much higher compliance number, that's of concern to us. We think it can really cause a lot of confusion.
Thank you. I'm going to pass it on to Chair Schulman.
Thank you, Chair Narcisse. So, Mr. Rich, if I heard you correctly, you said 70% of the hospitals comply with the federal price transparency laws?
Right.
Is that, okay.
According to the federal government.
Okay. So my question is, if most of the hospitals comply, why would this bill create an extra burden for them?
Well, the way we read the bill, it's not necessarily an extra burden on hospitals. Although I think I heard you say the other night that you mandate hospitals to do a variety of things in the bill, which it's not the way I read the bill. I read the bill as using publicly available information. So I don't see the bill as providing new burdens. My concern about the bill is using new definitions that the federal government does not use when it comes to compliance with their own rules.
So the most recent Patients' Rights Advocate study from 2023 notes that 6% of hospitals reviewed in New York were complying with the federal transparency laws. How do you explain the discrepancy between what you described and what they found?
I really can't. I don't know what definitions they're using. They're clearly not using CMS's own definitions and their views of compliance. CMS, in their report 2 weeks ago, where they announced that there was 70% compliance, they said that sometimes outside groups can see that there's a sort of a not applicable or an empty space or empty in these huge files. There might be something where there's a cell that's not filled in. And they said that could be because that hospital doesn't provide that service. Or sometimes they negotiate what they call a bundle, whereas a few different types of services are in one, in which case those other cells would be empty. So it really takes a lot of digging into these files, what shouldn't take a lot of digging into and should be improved if you're finding that problem, Councilwoman Menon, with the price estimators, is if there needs to be improvement there, that should happen. That is what would be most helpful as a part of the rule to consumers, are the price estimators, where you can go in, put something in, and it tells you what the price is, and that is part of the rule.
Do your hospitals timely and accurately file IRS Form 990s?
Yes, they do.
You mentioned before, and I know we've talked about it a little bit, about the prices being negotiated separately between the hospitals and the insurers. Wouldn't it be beneficial for you as an umbrella organization to have them all come together to negotiate in a way that leverages lower prices for consumers?
They wouldn't be allowed to do that under antitrust laws, which are pretty stringent, so they would not be able to do that.
The Greater New York Hospital Association has noted that the Centers for Medicare and Medicaid Services has made formal determinations that multiple Greater New York Hospital Association members follow federal transparency laws. Specifically, what number of hospitals have received these formal determinations? And if you can, is it possible to submit those formal determinations to the council?
I don't know that I myself have access to anything in writing. However, what CMS does is they both survey themselves, the websites, and if they have found that a hospital is out of compliance, they first require an improvement plan, and then after that is done, and when there's compliance to their satisfaction, then they have told those particular hospitals that they are in compliance. I can find out if there's something that I can get to on that, but that is my understanding of how the process works.
So the office, the Mayor's Office of Labor Relations was here earlier testifying. I think
Right.
that you might have been here. They said that there were two major hospital systems that refused to talk to them or respond to them. So is that something that Greater New York can help with? Because that's part of the many reasons we're trying to do this transparency.
We can certainly look into that. I don't know about those specific situations because, again, when it comes to negotiations, they need to be separate, and the hospitals can't really talk to each other about those, but we can certainly look more into that.
So if I were a patient trying to understand what a healthcare procedure would cost, how would I go about getting that information?
So you should be able to, assuming compliance with the federal rule, go to their website, and there are one of two things that the federal government requires. One is that they put the prices for 300 what they call shoppable services, sort of like the most likely services that you are not emergency services, obviously. However, they're very important services, that you would have the time to actually, okay, it costs this much at this place, it costs this much at this place. I think I'll go to this one because it's less expensive. Or put up a cost estimator tool so that you can put in what you're looking for, and that can go far beyond those 300 shoppable services. That can actually include a lot more in the cost estimator than the 300 shoppable services that are part of that option. You have the one option or the other option. So again, I think there are two parts of the rule. There's this part, which is extremely hard to comply with, as you can imagine. Again, that's not meant for the average consumer. I mean, I agree with you, that's crazy. You can't go through this as the average consumer. But the other half of the rule is really what is supposed to be the consumer-oriented piece, which is either the shoppable services being posted or the cost estimating tool.
What portion of overall hospital expenses are spent on uncompensated or charity care?
It depends very much on the particular hospital. I can tell you that in terms of community benefits, it's approximately 8%. When it comes to charity care, it's actually a lot lower than it used to be, because we used to have, before the Affordable Care Act, we had about 14% uninsured. We now have 5% uninsured in the state, so it's a lot lower. But I would have to get you the average. I don't know it off the top of my head.
Do you know how it differs from large hospital systems versus safety net hospitals?
I do not know for sure. I do know that New York City Health and Hospitals does see more uninsured than a lot of either the safety net or the other hospitals do. But it can vary amongst different hospitals. The safety net hospitals, mainly their problem and why they need subsidies from the state is mainly Medicaid underpayment being their problem, even more so than uninsured. Although obviously we have a huge problem with uninsured, undocumented immigrants in the city. And so that's something that we're all sort of supporting legislation in the state budget to do something about by enrolling them in the essential plan, for instance, so that they can actually have health insurance.
Okay, thank you. Thank you for answering my questions.
Sure.
So, thank you again for being here. Why would a service at one hospital cost more in the same identical service?
There are a variety of reasons. Some hospitals, as I mentioned before, can be more expensive than others because they are the ones that have they see the sicker patients. They might see the people who are transferred from community hospitals to them because they have the expertise to deal with whatever the issue that they have. So at the one hospital, it might be a lot less of a price that's negotiated with the insurance company than the one that has the much more, sees many more sicker patients, but also has the expertise to deal with the particular problem. So that can be one of the reasons. And then also a lot of the standby costs that I mentioned, that some hospitals have standby costs because they have to have burn units at the ready all the time, where they have to have, I'm sorry.
I got you on that, but I'm just saying if it's identical. Let's say the person is not a pre-existing diseases that we're talking about, maybe complicated or complex case, but we're talking about the same identical procedure.
Part of the reason why it's different is that one insurer negotiated one price with a hospital and another negotiated another. I'm not privy to those negotiations that each hospital has with the insurance company, but there might be different reasons why an insurance company would say, okay, we're going to negotiate a higher rate for this for you, but we're going to negotiate a lower rate at a different hospital. There could be all kinds of reasons that an insurance company would do that, including how many of their enrollees actually go to that hospital, their view of the quality at one hospital versus another, whole variety of things.
Because you have hospitals in the same network that more likely the negotiation is the same, and yet the cost is way different.
They could be different based on one of the things that I mentioned before, which is that, a lot of the systems are built around the academic medical center. So think of, some of the Manhattan academic medical centers or Montefiore. They may have a hospital in Brooklyn that the insurance company says, look, I'm going to pay you more at the Manhattan place because it is more expensive. You have more expertise. You have more of the equipment that's necessary. But the one that is in, the other hospital that's in your system doesn't have all of that. They often have to transfer someone to the larger academic medical center. So they may negotiate a lower price for the services at that other hospital within the same system.
I got that. But now when it comes to a person paying, so that's the reason we're here. We just want transparency. So before you go, like thinking it's an identical procedure and you have to pay, and most of the time those that are uninsured don't have those kind of money.
Yes.
And before they come, they need to know how much this procedure is gonna cost them. And it has to be crystal clear on your website. Those are the things that we're looking for personally.
Correct. Absolutely. No, I agree with you. And that's that second consumer-oriented prong of the regulation that I mentioned, that if it needs to be cleaned up or websites need to be cleaned up, that's true. But that's a federal requirement, and as CMS said 2 weeks ago, they're going to step up enforcement quite substantially. So I agree with you.
And we're not here for regulation. We are here, for transparency. We have been joined by Council Member Hudson, which I don't see here. Wait, Hudson? Yeah. And I'm going to pass it on to my colleague, Felice, for a question.
Thank you. Just want to thank Councilmember Julie Menon for your leadership on this issue, and I want to thank our two chairs, Chairs Narcisse and Shulman. So a few questions. So your position is that, obviously we have some federal regulations and that hospitals are already complying, and that this bill is somewhat duplicative. So if it's duplicative, how would it harm our hospitals?
My concern is, and thank you for your question, and you have in your district one of those safety net hospitals, certainly, that can't make it on Medicaid and Medicare alone. So thanks for your support of them. The problem that we have is we're not sure that it would be interpreted, or the federal rule would be interpreted in the same way that the federal government does. It's the federal government that enforces the rule. They're the ones the hospitals have to follow. They're the ones who could potentially be penalized $2 million, which is now the penalty for not complying with the federal rule. So that's what they have to follow. I don't know what the city group would come up with. I mean, they're already, apparently a lot of the advocates are not agreeing with the 70% that the federal government compliance rate that the federal government says exists. They say it's 6%. But I have no idea what that's based on. I know what the federal government's basing it on. They're basing it on what is in the rule, what's required, et cetera. But we just don't know, and that's why we're concerned. Again, if it were completely duplicative, I don't know why you would need it if there were, but if it were completely duplicative and they were using the exact same rules, the same compliance terms, then I don't think we'd have as much concern about the bill. But it's very unclear what the criteria would be.
So wouldn't a better approach be to ask the federal government and the city council, if we have the power to do so, to set some clear or much more clear definitions on the issue, rather than opposing a bill that would strengthen regulations?
I think there's always room for more clarity. Our hospitals are regulated by so many agencies at the federal and the state level, and a lot of times rules are less clear than they could be and require interpretation. And I think that is one of the things in the report that CMS came out with 2 weeks ago, where they said, we are committed to, first of all, making sure that the 30% are complying. But number two, if there are areas where we can be clearer, they provided templates for hospitals to use now to come out with these, for instance. But if there are templates that we can use and other enforcement measures we can use and other ways we can make it clearer, we intend to do that.
Yeah, two more questions. Just curious, what's the most you've heard any hospital charge for a COVID rapid test? Seen or heard?
I honestly have not either. So I haven't had a complaint brought to me about a charge for a rapid test, so I'm not sure.
Right, but putting complaints to the side, what's the most that you've seen a hospital charge for it? Have you looked into prices for them?
I honestly haven't. All my COVID tests have been at CVS and free, so I'm actually not sure.
Okay. And approximately how much time and effort do you think it'll take to actually, if you are a patient going to hospital, to look online and get the actual prices for these different services?
I'm sorry, what was the first part of the question?
If you're a patient going to hospital, how much effort would you have to make to go online and start looking into the different prices of different services for whatever services you're going for?
What should be, under the federal rule, is that hospitals have on their website either the prices that they have negotiated for 300 different shoppable services, meaning things that they would most likely be going to the hospital and looking up prices for, or they have a cost estimation tool that will allow them to put in, here's my issue, and the price would come up. And I should, as I mentioned before, the insurers now under the federal rules are going to be required to have those cost estimators by January 1st. It's more complicated on their side because, as I have said before, hospitals are not the only part of the healthcare system. There's pharmaceuticals, there are other providers, there are freestanding, for-profit ambulatory surgery centers, et cetera. So theirs will have a lot more in it than the hospital cost alone.
Yeah, well, just got to say those are all good ideas, but the federal government works very slowly, and we shouldn't wait for them. And if people are flying to the hospital for a medical emergency, I think they should get clarity pretty fast. Yeah, thank you.
Thank you, Council Member. Now I'll pass it on to my colleague, Council Member Brewer.
Thank you very much. We do get a lot of constituents calling us, as you can imagine, because they don't understand the bill that they received. And it's, they have insurance, they don't have insurance, but usually they have insurance. It's just very complicated. And maybe they haven't had the expertise to go on the website, or maybe their insurance just stated you have to go to this hospital for this kind of procedure, and that's your only choice. So they go there and they get the bill, and it's confusing. So it's my experience. So then I have the clout. I call the hospital. We sometimes talk to the president of the hospital. I know them all. I have all their cell numbers, all their numbers. And I'm able to arrange that this is not, often it's usually wrong, to be honest with you. Usually they should not have been charged, or maybe it's my calling that reduces it and clarifies it. But that's not normal. Not everybody can do that. So I guess my question is, and it does happen frequently. So my question is, it seems to me that something as this bill, we know, like we have the Public Service Commission. Con Ed is a mess. You can't get information from Con Ed. I have the numbers. I can call, but most people can't. They don't understand the bill. Why did they just get a $4,000 bill? I love the Public Service Commission. You send your note there, there's an investigation, and you get an answer. Something like that, I think, is a little bit what the Menon bill is trying to address. How do you answer the fact that people have so many questions about their bills? It's hard to get answers. And do you not think that something like this would be of assistance to the public?
First of all, it shouldn't be as complicated as you're describing, and that is something that should actually be improved upon. I do know that all the hospitals under New York state law are required to put on the bills, here's where to call, here's who to deal with, here's how you can find out about our financial assistance plan, et cetera. But yes, I know that it can be very complicated. I think these transparency laws from the federal government are going to be very helpful, especially even more so than the hospital transparency law, the insurance transparency law. The insurers are the ones who know what they've negotiated with each and every hospital. They're the ones who are going to pay the vast majority of the bill. They're the ones who know what you've used of your deductible so far this year. The hospital does not know that. They would know, what the copay is. The hospital wouldn't necessarily know that. So I think there's a lot of work to be done still to simplify all of this. I think the federal law is one that is in its infancy. It's only 2 years old. The regulation is only 2 years old. And I think there are kinks to be worked out there, but I think there's going to be a lot more transparency to come, especially when the insurers are required to be transparent as well.
I appreciate that. It's my experience that you're not always able, under your insurance, to shop for the least expensive. It's more, this is where you need to go, and then when you, like I said, you often get some information that is not clarifying. Those 800 numbers are challenging, right? I mean, they don't always have somebody answering it, and when they do, you don't get the kind of satisfactory explanation that I hope something like a PSC, which is sort of what I'm calling this, would give you. So in this very complicated city where we have excellent health care, but I think we do need something that helps us understand what it is that we're accessing and how it's different or similar, et cetera. Thank you.
Sure.
Thank you. Now I'm turning back to Councilmember Menon.
Thank you so much. I just have a couple follow-up questions.
Sure.
Councilmember Feliz was talking about if you knew about the disparate cost of COVID tests. So city workers were charged by Montefiore $1,000 for a COVID test. Do you know why they were charged $1,000 for that COVID test?
I do not. I don't know every single specific hospital situation there, so I do not know. I don't even know that story, so you'd have to ask them.
Okay, we know that as a fact, and I think you'll hear about that testimony later today. So that is obviously very troubling when COVID tests are free, and for any hospital to be charging a city worker $1,000 for a test is obviously unconscionable. Two more questions. We heard from the administration, specifically Claire Levitt from OLR, testified that she tried to meet with several hospitals to lower prices, and the hospitals refused to meet with OLR. Do you know why that is?
I do not know. I don't know about those specific circumstances. I really don't.
Okay.
I mean, OLR uses, my understanding, is that they rely on private insurance companies who have negotiated those different rates, including Empire for the most part. So the rates that they are paying are ones that were negotiated between the insurance companies that they mentioned they're putting out an RFP. That'll be the same thing. They don't actually negotiate those rates themselves, but I do not know about the specific situation.
Okay, it's just obviously very troubling when the city is trying to lower costs and the city workers and retirees comprise 10 to 15% of the population, so the city's trying to harness its purchasing power, but the hospitals won't even meet with them. My last question is, in your testimony, you spoke about the fact, and I'm going to read this sentence, it is ludicrous to believe that if somehow hospital payment rates were reduced, these plans would share savings with consumers. I strongly rebut that. If you look at other jurisdictions that have done price transparency, the state of California saw a 20% reduction in some savings. The state of New Hampshire, 5%. The state of Massachusetts, similarly. So obviously we know price transparency works. That's the intent behind the bill, to drive down costs and to give consumers the valuable information they need to be able to look at the different price disparities.
Well, it's not the experience we've seen. First of all, you mentioned states, not cities, which I think is a very important distinction. But I don't see why we have very dominant national, for-profit, publicly traded corporations who are the insurance companies in this city, including the one that owns Empire, including United Healthcare, including Aetna. They have shareholders to answer to, the hospitals do not. They transfer a lot of their profits out of New York State to their shareholders and to their parent corporations in Indiana and in Minneapolis. They don't reinvest that money back in the healthcare system in New York State. I think one of the questions is, how are they making such enormous profits off of New York's healthcare? I mean, that's one of the questions that we think, if you were going to have an office, I think that would be something that they would need to understand, particularly seeing the city is contracting with some of those very companies to provide the health insurance for their enrollees.
Yeah, I'm not going to get into a debate on it, but the issue is really the skyrocketing hospital prices, whether it's $55,000 at Montefiore for a C-section versus $17,000 at another hospital, whether it's $10,000 colonoscopy at one New York City hospital versus $2,000 for another. It's the skyrocketing hospital prices that are causing this issue, and that is why the bill is meant to address the transparency. So I don't want to get into a debate because I know time is short, but I did need to just state that for the record. Thank you.
Thank you. We're moving on with Council Member Yeager for question.
Thank you, Madam Chair. Good afternoon. Good morning.
Afternoon.
Whatever. We're afternoon now. You've spoken a lot about transparency and how much you support it, but you also don't like this bill. I'm just trying to understand through listening to you today what exactly about this bill is problematic, because it really doesn't require any member of your association to do anything differently than they're currently doing. The transparency and the information that would be posted would be based on publicly available information. The information is already out there.
Our concern is how they would interpret the publicly available information.
So your concern is that if we put this up on a website, people are too stupid to get it. And
No, my
therefore
concern is
you're
that
here to protect us.
No, my concern is that the federal government says 70% of hospitals are compliant, and other groups using who knows what criteria are saying only 6% are. That's a real problem for us.
No,
We'd like to know the
that, but
criteria that they would use to judge hospitals and grade them on, they have 3 grades that the federal government doesn't use in terms of compliance. The federal government says you're either compliant with our rule or you're not. The bill says transparent, satisfactory, or not transparent. We have no idea what criteria they'll use for that. And that's one of the concerns that we have.
Okay, so you don't have a problem. I'm just trying to parse out, it's a bill, right? It's a draft, and at some point, you can be guaranteed it's going to be adopted. It's got a supermajority of the council, not me, but a whole bunch of other people, enough to pass it. At some point, this bill is going to pass. I'm trying to understand which parts you have a problem with, and you certainly can't have a problem with creating the Office of Healthcare Accountability that would provide recommendations. How bad can that be? It would audit city.
I would be better if the name does not reflect the bill.
So we got a problem with the name.
No. I like the name. The problem is the underlying bill focuses almost exclusively on hospitals. There's a lot more to healthcare and healthcare costs than hospitals.
Well, let me get to the next part of what the office is supposed to do. It's supposed to audit city expenditures on healthcare. And that's not exclusive to hospitals. It's overall how much is the city paying for healthcare? It pays a lot of money for healthcare. Kind of want to get a bang for the buck, but it doesn't implicate necessarily. Unless you're concerned that there's something that we're going to find out that you don't want us to, it doesn't implicate the hospitals at all. The hospitals don't have to do anything. We're going to take information that we already have as a government. We're going to cobble it all together, make sure that there's one centralized office that has it. That office is going to create a website. It's going to make sure that there's a singular focus by an individual with a team who report directly to the mayor, who are going to be in a position to try to figure out whether or not the city is paying what it ought to be paying. Maybe it's paying too much, maybe it's paying too little. Your hospitals can make some more money. Well, let's try to find that out. I'm just trying to understand, and I'm not trying to be dense here. I just don't get the objection. I just don't understand it.
We don't have a position on the audit.
Okay.
Although OLR had a position on the audit, we don't have a position on the audit. What we have a position on is taking federal rules and regulations and then potentially reinterpreting them in ways the federal government doesn't recognize, doesn't enforce against hospitals, or creating different standards than the laws that the hospitals are supposed to be following under federal law.
Okay, but I want to be clear. This is not an enforcement bill to the extent that there are penalties involved, nobody's getting punished, there's no fine, the city's not imposing a fine on a hospital that doesn't do X, Y, and Z in compliance. It is simply taking information and putting it in the public domain so that, members of the government, people who are supposedly on the board of directors of this municipal enterprise, and also the general public can have an opportunity to see. If you're saying that the people are not, able to understand it, well, that's okay. There's a lot of information on websites that we don't understand. I don't understand it. That's fine. But I just don't get the objection, because the hospital doesn't have to do a single thing if this bill passes, other than continue to do whatever it is that it's doing. All that will happen is that the city, the payer, the customer, will have a little bit more information, and I think more information is always good. I guess that's not a question, so anyway, I appreciate you being here. Thank you very much.
I believe it or not, I'm in agreement with the statement that you made. It's just like we're not regulating. And I said that many, many times. We are just here to look for transparency. There is no regulation. This is not our land, and I love to stay in my lane. So I'm staying in my lane. It's just transparency, make it more accessible to the people that we serve. That's all. So having said that, I want to say thank you. Anyone else have any questions? So thank you for your time. We
And if I could,
appreciate it.
Councilmember, I just want to thank you for your letter and your advocacy for the state budget, especially as it related to Medicaid and safety net hospitals. We really do appreciate that.
I believe health is wealth. So I'm going to keep on fighting for quality health care, and thank you for your service.
Thank you.
Thank you.
Apologies. Okay. We're going to move on to the next panel in person. Cora Opsahl with 32BJ, Henry Garrido, and Pat Kane. We'll start with Cora when you're ready, please. Thank you.
Good afternoon. Thank you so much for the opportunity to speak this afternoon. My name is Cora Opsahl, and I am the director of the 32BJ Health Fund. I'm testifying today in support of the legislation to establish an Office of Healthcare Accountability within New York City. 32BJ Health Fund provides health care benefits to over 210,000 32BJ union members and their families. Our members are frontline workers that keep our buildings in order and airports and schools moving. The Health Fund provides health benefits with no employee premium sharing. As a self-funded plan, the price of health care directly impacts our budget and ability to keep costs low for our members. Currently, the 32BJ Health Fund has access to hospital pricing information through the claims data we receive from our third-party administrator. We have a 20-person analytics and data engineering team that uses this information in addition to other publicly available data to drive our decisions. However, as has been mentioned in other testimony, because a recent report showed that less than 10%, in fact, only 6% of New York City hospitals are in full compliance with the federal transparency laws, we're very limited in our ability to make valid comparisons across hospitals and providers. It's also very challenging to gather data from so many different sources and do the work to make it viable, and we have 20 folks to do it. For employers that don't have an analytics team like we have, it's even more challenging. A centralized entity that collects and disseminates this information would be a game changer for us and for many other employers who are trying to manage hospital prices. We are often asked why 32BJ Health Fund focuses so much on hospital prices. While we understand that many factors contribute to expensive health care, the data indicates that the single biggest escalator is hospital prices. Since 2009, the Bureau of Labor Statistics has tracked an 80% increase in hospital prices, compared to a near 30% in drug costs and a near 50% increase in healthcare costs overall. Hospitals account for nearly 40% of dollars spent on healthcare in New York State, compared to just 14% spent on drugs. By contrast, we at the 32BJ Health Fund spend about 5% of our total operating expenses on our internal overhead and external administrative costs. So in the end, hospital prices really matter. We also know that the price of care in New York City varies by a wide margin. The price the Health Fund paid for colonoscopies between 2019 and 2021 varied from $2,185 at New York City H&H to $10,368 at New York Presbyterian. We need transparency in hospital pricing and explanations for the wide difference in the prices for the same procedures. Because again, hospital prices matter. We understand that different hospitals have different costs and requirements, and we support efforts to more fairly compensate our public and safety net hospitals whose financial profile often stand in stark contrast to many of the city's more well-heeled private hospitals. Better data will allow us to take this into consideration in what we pay different hospitals. For public and safety net hospitals, prices truly matter. In sum, the Office of Healthcare Accountability will provide us with important information to support market-driven solutions to high healthcare costs. It also reinforces New York City's commitment to federal transparency laws, thereby motivating more hospitals to comply. We commend the City Council for its groundbreaking work on this legislation. Thank you for the opportunity to speak.
Thank you. Now we're moving on to DC 37.
Good afternoon, Chair Schulman, Narcisse, and members of the Health and Hospital Committee of the Council. My name is Henry Garrido. I'm the Executive Director of DC 37, the largest union in the city. We represent 150,000 members and about 90,000 retirees. I'm here today to support Intro 844, which would establish an Office of Healthcare Accountability. I want to personally appreciate Councilmember Julie Menin for sponsoring the bill and the chairs for holding this hearing at this important issue to light. For years, hospital prices have steadily increased, and as a result, it is now the biggest escalator of hospital costs and healthcare costs overall. In 2021, the federal government passed a law that required hospitals to post the charges, negotiated prices, and cash prices. Unfortunately, much of the data is posted in an unreadable, machine-readable file formats that make it difficult for patients and organizations to understand the information. Intro 844 takes the federal law further by creating an Office of Healthcare Accountability that would collect and publish pricing data that hospitals should already be posting and make it easier for the public to access the information for use. The Office of Healthcare and Accountability will have the authority to make recommendations on how to lower the cost of healthcare. It would also require to create a public accessible website that provides information on the cost of hospital procedures and summarize the cost transparency for each hospital. Finally, where feasible, the office will report on the factors external to hospitals, such as the operating and profit margin of major insurance providers. This office would help patients maneuver through the complex world of hospital pricing for approximately 300 procedures, since the information will be housed in one specific site, and provide a standardized list for all procedures. This will make it easier for patients to accurately compare prices between the different hospitals. As consumers, we price comparison shop for gas, grocery, and even for expensive items such as homes and automobiles. Yet there is no mechanism available for patients to compare the cost of medical procedures by hospitals. These checks and balances in Intro 844 provide much needed transparency and information in hospital pricing. For too long, these private hospitals have gone unchecked and allow for charges, whatever they need to various procedures. They need to be held accountable into the pricing. I won't read the rest of my testimony because I'd like to address something that was said earlier at the testimony by the Greater Hospital Association. If you take the price comparison requirement that was named for Columbia Presbyterian, for instance, the shoppable convenience list that they put of the 70 procedures online, you find most of them pricing for insurance and for uninsured patients, depending on which is your provider, that the numbers are just untrue. Numbers don't lie, where people use numbers to lie repeatedly. We need an office that would really hold those costs accountable and to demonstrate the true cost to the patients, not an estimated cost based on factors that they've already filtered, but an actual cost to the patients and to the workers. Let me just say lastly that, as I mentioned earlier in my press conference, 10 years ago, the cost of providing healthcare for city workers was $3 billion. High enough. About $800 million of that was hospitals. 10 years later, that cost is now $12 billion. Of that, hospitals are 62%. Doesn't take a genius to say, even when the number of procedures went down during COVID, where selected procedures were reduced because you didn't have elective procedures anymore, the cost went up by 150%. So tell me how that's possible. How is it possible for hospitals to keep robbing workers of their hard-earned dollars and without any accountability at all? So for that, we support Intro 844. We'll submit the testimony for your consideration, Madam Chairs, and thank you for listening today.
Thank you. Now we're moving on to NYSNA.
Good afternoon. Sorry, my name is Pat Kane, and I'm the Executive Director of the New York State Nurses Association, representing more than 42,000 nurses across the state. I really want to thank you all for the opportunity to testify today and for your really important work on this issue that we've been talking about for a long time at our union. The rapid rise in the cost of health insurance, driven in a large part by escalating hospital prices, is well established in 32BJ's report and other research. I want to focus my remarks on how this problem is impacting nurses and other healthcare workers in terms of wages and working conditions. Our members went through an extremely difficult and traumatic experience during COVID. Hospitals were already short-staffed due to the workforce practices of many hospital systems, and the pandemic only revealed and worsened those conditions. The hospital industry has experienced a wave of consolidations and the creation of large hospital networks that are also acquiring physician practices and other healthcare services to maximize their market power and generate profits. These hospital networks are all nonprofits because New York state law does not allow for-profit corporations to own or operate hospitals. And despite their nonprofit status, these networks increasingly act like for-profit corporations. They are driven to reduce their labor costs by understaffing and underpaying, and to increase their revenues by shedding unprofitable services like psychiatric and maternity services that our communities so desperately need. They focus their marketing efforts on patients with private insurance and leave low-income, underinsured, and Medicaid patients for the safety nets to handle. In pursuing this business strategy, wealthy hospital systems force consumers, patients, and their employees to pay unconscionable prices for services. Some of these hospitals, as you know, charge 3 or 4 times the rates paid for the same diagnosis by Medicare. Nursing is already one of the most dangerous jobs, with very high rates of injury and illnesses contracted at work. COVID only made the physical and mental toll worse. But when we went into bargaining for our private sector contracts last year, the hospitals took the position that they could not afford to pay the nurses' health benefits and that we should reduce the quality of that coverage and pay more in premiums and copays. This stance was especially infuriating in light of the facts that one of the major drivers of high costs is the pricing and business practices of the same hospitals. We had to push back to preserve our health coverage, and the high cost of health care were a major sticking point in our negotiations. In the end, we fought back to win fair wages and preserved health benefits of active and retired members so that we could continue to provide the care New Yorkers need. I want to cite just a few figures before I close my comments. The New York Presbyterian Hospital Network has some of the highest charges for many procedures in the city of New York. In 2021, according to their financial statements, Presbyterian made more than $1 billion in profits and has $19 billion in assets. The CEO of Presbyterian made more than $11 million in 2019, according to federal filings. I could give many similar examples from other big hospital networks. We think enough is enough. We have to start to fix the problem, crack down on these abusive hospital business practices, and for these reasons, NYSNA strongly supports and urges the council to pass this legislation. Thank you.
Thank you. If we can keep the answers to the question a little tight, because either we have to leave the room, go somewhere else, because we have a second hearing, or we can try to do our very best. So we're gonna do our best. No rush, because it's important. What have you observed about the cost discrepancies in the city when it comes to healthcare?
Sure, so I'll take that first. You know, I think that when we look at our data, it's really clear that there is cost discrepancies across the board. So, and I know Councilwoman Menon has mentioned the colonoscopies. You know, we've looked at our own claims data, and we can see that you can go and get, and a colonoscopy is a great example because it's about as ubiquitous of a surgical procedure as a non-clinician can talk to. I'm not a doctor. But, you know, we see that it's somewhere for $2,000 at New York Presbyterian, or, sorry, at New York Health and Hospitals, or $10,000 at New York Presbyterian. We've seen the same thing when you look at vaginal deliveries or cesarean sections, or things like, you know, basic echo heart procedures. And the wide variety also doesn't correlate to quality. And so from our data really shows that there is no, from what we can tell, any really reason for the wide variety and disparity in pricing.
And the colonoscopy part is something dear to me because I'm always in the procedure room for colonoscopy.
I'm sorry to hear that.
No, I help a lot, especially when there is no staff. So I'm the staff for my partner back in the days. But so they don't pay that much in Brooklyn, that's for sure. Thank you. Yes, Henry.
Yeah, I was going to address that. In addition to that, I think you heard earlier the issue of a simple COVID test being charged over $1,000 is actually over $1,050 by one hospital system over another with no possible explanation. And I want to reiterate something that was also mentioned by Councilwoman Menon, which is as the head of the MLC, right, co-chair of the MLC, the head of MLC, Harry Nespoli, and I, went with the city and requested to meet with the hospital systems to try to get an understanding from their perspective why there's such price discrepancy, right? And there were 3 hospital systems that flat out refused to meet with us, flat out refused to the city. And when we asked, well, why? They said, because we don't have to. It's the kind of arrogance that we have seen by these hospital systems. And so when you look at an explanation for the discrepancy, even within the same facilities of the same hospital network, 2 hospital facilities located in different locations, and because we're city workers, we're being charged significantly more than what, say, a private insured patient was. What's the explanation for it? They don't provide one because they don't have to. This is the kind of arrogance that we need to eliminate, and this Intro 844 begin to address that by making the data publicly available.
All right. How do hospitals play a role in healthcare costs?
but the nurses. Hospitals are one of the major drivers of healthcare costs, and those costs are passed on to a lot, not just union members, right? Healthcare costs drive inflation, really affect the quality of people's lives, as we're talking about, and as somebody previously mentioned, folks are often put in a position, whether they're represented for collective bargaining or not, because of the increased healthcare costs of actually looking at trading their livelihood, their ability to earn a decent wage, or their health, which is really ridiculous. But hospital costs contribute astronomically overall to healthcare costs. And this is one of the reasons that, we try to keep patients as much as possible out of hospitals. Try to keep people healthy, because we all know that inpatient care is definitely more expensive than preventative care.
Amen. I would say amen to that if I was in church. That is definitely. How do health insurance companies play a role in healthcare costs?
They're enablers. They basically, a lot of the times, one of the concerns that we have is that there was no there was no transparency by which the insurance companies negotiated rates with certain hospitals and made it explicitly so in the contract. So even the ability to audit back prices that were higher were explicitly prohibited in some relationship between the insurance and the hospitals. For that reason, I think they are enablers, and we need to break that relationship in a way that benefits the patients and the consumers, and not this whatever relationship they have. And I think you heard earlier one example of what happened to the fight between United Healthcare and Montefiore sometime. For that year, those patients in that area where there's essentially, and I'll say it, a monopoly in the Bronx, went without services or had to pay out of pocket just because of a dispute between the two, without transparency as to what the dispute was really about, right? Other than greed. I'll say it, greed. So this relationship is an incestuous one, and one that this kind of bill could go at the court of breaking. We need to do this, and we need to do this now.
Thank you. How do private health insurance rates compare to public health coverage, such as Medicare, Medicaid, and the Essential Health Plan?
So, excellent question. So it is all of our data shows that as a commercial payer, we are paying multiple times more than what we would be paying in Medicare. The 32BJ Health Fund did an analysis of what our claims would have been from 2016 to 2019 had we paid Medicare rates. We would have saved $1.1 billion during that time frame. And while it's not quite the same numbers as Henry can speak to what the city could save when we're looking at the same type of comparison, but right now, when you're looking at things where 400% of Medicare at some of these not-for-profit private hospitals, you have to wonder why are commercial payers really, being forced to pick up the difference in those prices.
Anyone else? Okay, do other costs or factors create a barrier to care for your members?
Yeah, I think location, we talk about zip codes and the location. I was particularly enraged when I became the head of the union in 2015 and found that there were very little providers, in many instances, no providers, for instance, in the Bronx, when I'm representing 30,000 people there. And that there was essentially a monopoly, as I said, in some providers. And the fact that people had to travel and also get their care in a very specific zip code, it's a problem, right? For people, especially for seniors and people that have mobility issues and transportation issues, was a big difficulty. I think also the true monopoly of specialists who refers people back to hospitals. One of the strategic pieces that they did is, well, if I do all the specialists in a particular area, then they can only refer people back to us. So if you go to see a primary care who refers you to a specialist who then says to you, I only have admitting privileges with a particular hospital, you've created a pipeline for that person to not be able to choose between providers, but just basically monopolize the system from the beginning when the person goes in with an issue to the end when the person may have to have surgery, and at the back end after surgery and post-op services, which means that they can also control the cost of the rates of those particular specialists. That is a problem. The lack of access and diversity, and that has been a strategy. Secondly, I want to talk about this negotiating pools that they talked about. One of the most difficult things to do is that these hospitals come in as a negotiating group for rates with already preconceived ideas. It makes it extremely hard for hospitals in the area. Like, we have 100+ hospitals in the area, but basically we negotiate with the 5 groups. Makes it very difficult to break that. Now, that might be a business strategy for their end, but from the consumer point of view, it's horrible. Because, I think if they come in with a preconceived notion of what the cost would be rather than the actual cost is, then you have a problem, right? And your only option is, if I don't take your pricing, you're going to put me out of network, and my members and members of the city unions, city workers are going to get upset because you took a network out. Here's your model. Take it or leave it. We need to do better than that. And I think one way that we can do better is by having true transparency in the cost disparity that you mentioned, that Cora mentioned, that we've seen across the board in both public and private institutions. And also, let me just say, hundreds of millions of dollars of taxpayers' money are given to these hospitals because they're non-for-profits. They don't act as such, many of them don't. And so we should be holding them accountable to say, hey, we're giving you massive tax breaks on property taxes, on a number of things. What are you really doing for the public? What are you really providing? Are you diverting patients that are underinsured to another public service, to H&H, because they can take it and you won't?
If it's one big positive things you're going to say that can come out of Intro 844, what it would be, that's for all of you.
I think ultimately just having the tool, having the transparency, and really empowering patients, workers, to see what the prices are, and really, it gives people the power to create different networks. In our fund, we're self-insured. And, we're sitting, it's a Taft-Hartley plan, we're sitting across from those hospitals. And when we try to bring up prices and how to generate savings through looking at prices that different hospitals are charging and their networks, they tell us they can't talk about that. They won't talk about it. So I think just, being able to really rein in the costs, see what's going on, generate, more healthy competition. I was thinking today, I've never really seen, I worked in the OR for 30 years at Staten Island Hospital. I never saw a designer appendectomy that was worth, that kind of price tag, as opposed to like a regular appendectomy. Like Ann Goldman said earlier, it's an appendectomy, right? And, we're here to provide the same quality care to our patients regardless of zip code and regardless of what patients are charged. We believe very strongly healthcare is a union right. And I also want to say, as far as nursing goes, I don't think in your hospital bill you'll find a separate charge for nursing, right? Hospitals are still billing for nursing. Doesn't matter what the intensity is, as part of like a room and board charge. So that's kind of interesting too. Interesting.
I would say that similar to what you're saying, is that transparency is the win here, right? You can't fix the challenge of healthcare and healthcare affordability if you don't know how much it costs.
That's it. Thank you.
Yeah, I would say evening the playing field, right? Give the consumers a chance. And we negotiate contracts for a living, and we like to think that we're really good at it. But we can't negotiate a contract if the rules are fixed so that you are already as a disadvantage. And part of the rules being fixed is the way the pricing are skewed to certain hospitals and the way they play with the numbers that make it almost impossible for you to have an honest negotiations and even in the playing field. I think it's critical in this bill.
Thank you. Now I'm going to pass it to my colleague, Chair Schulman. You want to yield to it?
Thank you. I want to thank this panel in particular, and I just, Ms. Kane, I want to mention, it's interesting, when Greater New York was here, they talked about the reason why there were discrepancies between the insurers and the hospitals, that some of them was quote-unquote specialty hospitals. It sounded almost like we were paying for the overhead of these particular specialty hospitals, which become specialty institutions for various reasons. So I want to mention that. So I wanted to ask all of you if you can talk about how hospital pricing and cost transparency impacts negotiations at the bargaining table.
I can tell you that on January 1st, 2022, the 32BJ Health Fund removed New York Presbyterian and all of their affiliated hospitals and physicians from the network. We anticipate it'll save us over $30 million in 2022 alone by removing the highest cost hospital and affiliated doctors from our system. I'm not the union, but I can tell you that because of this cost savings, the union worked on the residential contract negotiation, and in April of 2022, resolved the residential contract, being able to grant a $3,000 bonus to their members, the largest wage increase in history for this contract, and then on the employer side, granting a 2-month premium holiday for the employers, plus holding our premium increases to 3% in 2024 and 2025. So that I would say is really clearly the impact of what understanding our pricing does for us.
Since the time of the fiscal crisis in New York, most unions, public sector unions negotiate, all public sector unions negotiate on the basis of what we call the 1% rule. Basically, there's a labor reserve that is set on that 1%. What is the cost of 1% for city workers? That then gets put into the budget. We've heard about it since we have recently, thankfully, negotiated a contract for our members. The cost of that 1% has increased exponentially by the cost of healthcare and fringes that are there, and hospital is the #1 reason for it. Even in the rise of cost of prescription drugs, that has been also an increase. We've managed to do an RFP to control that cost. That 1% becomes larger, so therefore there's less money for wages for the workers. We saw, for instance, in comparison, where they're being controlled and out of network, where the workers were able to get more than city workers exponentially. So we felt that this was a big issue, right? And to the extent that you hear so much about the rising cost of healthcare, think about if we were able to do that and hold them accountable, that $2 billion alone could have been an additional, if you think that cost of 1% is $450 million, you can do the math. Yeah. How much more could you have paid the workers? And now we have a huge recruitment and retention issue in the city of New York. We have 25,000 plus vacancies. That doesn't include health and hospitals. We're looking at the cost and how much people are leaving because we're not able to raise wages. And healthcare costs is the #1 issue for that, right? We're looking at how public hospitals are now understaffed, and where they want to recruit respiratory therapists and nurses aid, and private hospitals are part of the affiliated hospital that's supplying, have been able to control their costs on hospitals. We have not because of this kind of situation. And so it doesn't take a genius to see the numbers, right? And the direct effect of having to limit how much raises you can do for workers and how much salaries you can do in a competitive market if most of it is going to your healthcare. And that's a fact, and that's the fact we're suffering from.
Yeah, I mean, in our most recent contract negotiations, the cost really played a big part. It was 17,000 nurses in 12 facilities in New York City. The only facility that it wasn't part of our benefits fund was actually Montefiore. And our benefits fund, we're self-insured. It's 39,000 lives that we're covering through the fund. The cost, we were in a situation where that fund would have run out of money this month in February if we weren't able to get, of course, from our side, we wanted increased contributions. The management side wanted to put wanted the workers to bear the cost of the increase. We were able to, and I think you all know, what we had to do to be successful to get the kind of wages that we needed to recruit and retain nurses that we so desperately need and maintain their health care. And I want to say, when workers, obviously nurses are paid at a different level than a lot of other workers. And we've been very fortunate, but for workers, we're talking about prevention, quality of life, and we all know about the social determinants of health. So when a worker is forced between health care and a living wage, when you think about those choices, that wage is going to affect their health, their ability to have proper nutrition, proper housing, and all the other things we know that really impact their need for health care to begin with. So it really is a Sophie's choice for most workers. That's just not right.
Thank you very much, and I just want to say that I am also committed to helping on the state level too, because this is one piece on the city level, but we also have to go to the state and federal level. I mean, I understand that Congress is in a different place now, but we have to do this coordinated so that this doesn't keep festering and that we can do what we can for all of our workers, because it was so important during COVID and so important to, as a recent breast cancer survivor, I can tell you that everybody from the techs, everyone, nurses, was so kind to me and so good, and we have to make sure that we give back to them, so thank you.
You're trying to say nurses are the best? All right, I'm going to move forward to my colleague, Julie Menon.
Thank you so much. I really want to thank all three of you for your very compelling testimony today, and I just have two quick questions. Without this bill, where would you predict that healthcare spending will go in the coming years?
I just have one word: up. I mean, but realistically, when we look at how much hospital prices and how much healthcare spending has increased over the last 10 years, especially in comparison to, even the rising cost of living, it outpaces inflation multiple times over. And without the ability to see what we're paying for, it's just going to continue to go up.
And I would add significantly higher, right? Not just up, but significantly. And by the way, it's because of what I mentioned before, right? Your negotiated position is not the same when hospitals are either hiding cost or coming in with a take it or leave it attitude that our members will resent, right? For city workers and their families that we provide healthcare for 1.3 million people, it's very hard to say to a member, well, this hospital network is not going to be there because of their behavior, right? So it's not like what happens with cable when a particular channel is going to be limited. You're talking about life and death situations here. People's services, right? And this is not something that you're going to be doing without a channel. So it's not only in terms of pricing significantly up, but also what is the effect on people? We're talking about human beings here, right? And these hospitals claim poverty all the time, but yet are able to pay, millions of dollars in bonuses and raise the salaries at the same time, with a very irony, the same city workers that they're benefiting from can go years and years without salary for the same reason, right? So there's an absolute inequitable approach to this, but I would say significantly up is what we would expect.
Agree.
Okay, and last question. From 2014 to 2020, New York had the highest average growth in per capita healthcare spending. I spoke earlier about some other states that have enacted price transparency. What has been your experience in terms of talking to other jurisdictions who have adopted price transparency?
So our experience has been, and I know there's some testimony later from some folks in other states, has been that when we adopt things like this, change does happen. Because again, I think, there's the common phrase, sunshine's the best disinfectant, and this is true here too.
Yeah, and I would say that for us, since 2014, we established a lot of price controls at the early, in order to try to, help change behavior, right? We increase copays in certain instances to discourage people to show up to the emergency room where an issue could have been handled through either an urgent care center, and remove copays to encourage people to go to those primary care centers. We did a program called the Advantage Care Physicians, which opened new centers where you're able to get more services on a 24-hour kind of operation, and facilitate the services to steer people away from the hospital behavior. And if you look at, for instance, what Chicago has done as compared to New York on price transparency, their rates have been able to be significantly lower because the unions have been able to negotiate better rates because the transparency was there. We need the same. And we believe that this is critical to the future of New York. Otherwise, this 13 billion, 12 billion is going to become 20 and 30. Where does it stop? It won't stop. And we need some price controls on this.
And I think, what Henry was talking about is an example of having the transparency, but then, it's what you do with that information, right? And I think, New York is a place where we can really lead. The city is a place where we can really lead and hopefully show, other parts of the country that this can work for them. But I think this is an area that once we have this information, we've seen what happened in other jurisdictions. I think we can really lead on it and make some great changes that will really improve everyone's lives.
Great.
Thank you. If you see us going back and forth, we have to determine whether we're staying here or we have to transfer to the next room. As you can see, some others are coming. So I want to say thank you for your time. Thank you for your testimony. That really give us some clarification in some of the wondering question of the constituent and as well as us. So thank you. I appreciate your time.
Okay, we are staying in the room for now. All right, we are going to be moving on to our next in-person, well, we actually have a hybrid panel now. We're going to have Lisa Young-Rubin, Sue Ellen Dodal, and then joining us virtually will be Marianne Pizzatola. I'm going to start with our in-person panelists, and then we will move to Marianne virtually.
If it's possible to get Ms. Pizzatola on first, we'd appreciate it.
Okay, so we'll hear from Marianne first then.
Marianne, you may begin.
Thank you, Chairs Narcisse, Shulman, and other committee members. My name is Marianne Pizzatola, and I am president of the New York City Organization of Public Service Retirees. We have many concerns about this bill. We have asked the council to investigate our healthcare expenditures several times. We contacted the Oversight Investigations Committee several months ago. At the January 9th council hearing on the mayor's bill to amend the Administrative Code 12-126, we specifically pointed out the misuse of Health Insurance Stabilization Fund. And in emails to council members, we pointed out the fiduciary failures of OLR, a mayoral agency. We need oversight and accountability from this council, not more bureaucracy. Our fear is that this new office proposed by Intro 844 may be a way for the city and the unions to get around the judge's decision in our last round of court. They usurp the current protections that the city council currently offers to retirees. And why do we think this? Because the city council the city and the MLC have made a practice over the last few decades to water down health coverage, create obstacles in that coverage with prior authorizations, narrowed networks of providers, and increasing copays on employees and retirees in the name of savings. They've also repeatedly suppressed the HIP rate as per the health savings agreements, which guarantees that the equalization payments will be larger every year. The city will keep saying that the unions owe them more, and this is not a way to negotiate savings. We have a bill pending in the council that would protect a retiree's vested health benefit because we fear the tactics that have been used for savings and have become victims of it with their Medicare Advantage scheme. We hope that vested retiree benefits would not be collateral damage from Intro 844 if it is passed, so we are offering our concerns ahead of your vote. We have seen several attempts made by the city and the unions to sell off our retiree health benefits in exchange for active raises. What guarantee do we have that this will not happen again for the sake of savings in this new office? We have raised the following issues several times with OLR regarding overpayments of retiree health care. A retirees being overtaxed by the IRS because the city has their domestic partner on the wrong plan currently. A retiree whom the city is overpaying for their spouse's health care plans. A city paying for 2 deceased spouses of retirees for over 5 years. And the city paying for a full family GHI plan for a couple on Medicare Advantage. And these are just a few. If the Mayor's Office of Labor Relations cannot manage its current fiduciary responsibilities, creating another office under the mayor is not going to solve the problem. The wait time currently at OLR to answer a call can be hours. OLR has even used Emblem Health personnel to handle employee and retiree calls in the OLR offices. We should not be including diminishing care to save money for the city, but real innovative ideas, and we have come up with a few. OLR and OMB have repeatedly negotiated deals with labor that does water down care, transfers costs to labor or the retiree, and that's not a real savings for any of us. The city added 12 plans in 1986. The idea was more competition would increase service and drive down costs. How we look at finding savings should change because the city saves, but at what cost? The lives of the workers and retirees pay financially. Please investigate these issues now, as you have right before you. In 1996, Governor Pataki said that ending the state's decades-old practice of setting rates for services provided by hospitals would allow competition and push down costs. And 27 years later, we see that didn't go as planned. But we are glad to see that the council is recommending that state regulate hospital costs once again, and we support that. But here in the city, we would prefer if the council conducted the investigations into these issues we've raised several times, implement our blue panel ribbon.
Thank you. Time has expired.
And provide enforcement powers to the controller to save our benefits and tax dollars. Thank you.
Thank you. And the next panelist, try to make it short, please, because we have to move out of this room.
I understand. My name is Sue Ellen Dodell, and I'm testifying on behalf of the New York City Organization of Public Service Retirees. The council doesn't need to create this new office. Under Charter Section 29, the council already can investigate any matter relating to the property or affairs of the city. Why isn't the council providing oversight to demand that OLR do a better job to ensure that health care provided to city employees and retirees is high quality and delivered efficiently? Why would you want to create a new office under the mayor when the existing office has failed in its fiduciary duties? Why don't you ask the controller to perform a comprehensive audit of the city's expenditures on health care? This bill can't affect the pricing of private hospitals. As you've heard, the state used to regulate prices for hospitals, but Governor Pataki removed those regulations in the mid-'80s. That's been a disaster. We need a return to some oversight by the state. I think it's very telling that you're considering a resolution today that would ask the state legislature to create an independent regulatory body to oversee hospital pricing, but you're also considering a bill at the city level that would put responsibility on the mayor alone to provide for the disclosure of hospital pricing and to audit city expenditures on health care. This bill will not help city residents, employees, or retirees get better health care, nor does it control health care costs. Rather than create another bureaucracy, you should mandate that a blue ribbon commission that meets in public and includes all stakeholders review all aspects of health care, including how to save money. The bill assumes that transparency in hospital costs, something that federal law currently mandates, will lower costs. But costs will just be shifted to those who can least afford them, including employees of the city and its retirees, who will be saddled with increased co-pays and reduced networks, including, quote, tiered hospitals. The bill assumes that if a city resident knows the price of a procedure, they'll go to the cheapest hospital. But there are many considerations in choosing a hospital. And of course, when someone has an emergency, they don't have time to shop around. In short, the bill creates a redundant bureaucracy. It's unlikely to accomplish its goals, and it likely will result in increased costs to vulnerable New Yorkers. We look forward to continuing to work with the Council on healthcare issues. But please delay any vote on this bill until you address our concerns. Thank you, and I ask that my entire written testimony be included in the record of this hearing.
Thank you. Next.
Good morning, Madam Chairs, distinguished members of the Health and Hospitals Committees and the New York City Council. My name is Lisa Young-Rubin. I'm a volunteer with the New York City Organization of Public Service Retirees, having retired from the New York City Council. While my colleagues and I support the goals of hospital cost transparency and ultimately reduce costs of hospital-based treatment for city retirees and employees, we also note herein some of our concerns about the possible outcomes of these endeavors. These concerns include, one, the tiering of hospital facilities, including clinics, to the possible health risk to city retirees and employees with this tiering based on what could be inconclusive and incomplete data. Two, the compromising of the medical privacy safeguards for city retirees and employees in the midst of what could be wide-scale sharing of medical records both inside and outside of City Hall. And three, what could be needless duplication of efforts and preemption issues in establishing a new office, especially in times of city staffing shortages and financial concerns, to address issues already under federal jurisdiction and that could be addressed by current city offices, including the New York City Council itself. Due to time constraints, I will submit the balance of my testimony for the Council's records, but I just want to emphasize that the tiering of hospital facilities would apparently be based solely on perceived costs and not on the actual quality and safety of the care. We note it might be impossible to provide a complete and accurate comparison of costs of medical procedures since each healthcare consumer has a different medical history and medical needs. Thank you, and I would like to submit my entire testimony for the record. Thank you.
Thank you, and I appreciate you staying in the time. We're gonna take a break and move to the next room. It's 5 minutes? How many minutes? About 5 minutes break, so we can make the transfer. We're gonna go to the next room. And those that come for the other hearing, you stay in this room. But the health part, we go into the next room. Thank you for your patience and your understanding.
Hi, everyone. We are back online and ready to proceed. We're being asked to do a microphone check by IT. If we can do a microphone check.
We copy you. Thank you.
Great. Okay, we're moving to our next in-person panel. Sorry. All right, 1 second, sorry. Okay, thank you everyone for your patience. We're going to proceed. I'm going to call up Barbara Caress, please. You can proceed when you're ready. Thank you.
Thank you. Thank you for scheduling me, and feels like a more intimate space, so I'm going to be a little bit more informal, if that's okay. I'm not going to read my statement. We will submit it in writing. I make a couple of arguments, and let me summarize them. The first is that the cost of health insurance is directly related to the cost of health care. In the case of the city, for example, healthcare costs, claims, constitute 90% of the premium cost, of the annual premium cost. The other 10% is administration, taxes, profit in the case of Empire, or margin in the case of Emblem. But so the city health insurance cost is about $7.5 billion, and 6.75 is the cost of healthcare. And what drives the cost of healthcare in New York City is the price of hospitals. So that's my second point. My third point is that New York City hospitals are among the most expensive in the country. We have some very reasonably priced hospitals led by Health and Hospitals Corporation. We also have 3 of the 50 most expensive health systems in the country, NYU, Presby, and Montefiore, and all of our big private systems, pricing is in the upper third of hospital systems across the country. The cost, New York City is a very expensive place to get health care. On average, our health care costs are about 20% above the national average. Our hospital costs are what drive it. So, and the data is in my written testimony. I took a look at the cost of the spending in the city employee health plan, the comprehensive benefit plan, which is the plan that 70% of city employees opt into. And I had data between 2014 and 2018. So in that 4-year period, the cost...
I'm sorry to interrupt, but it seems that we're having an issue with the live stream, and so we're going to have to pause for now until the live stream is up and running. Thank you.
Should I go on?
Not for now. We have to take a pause. Thank you. Okay, it's up. Sorry about that. You can proceed.
Okay, that's no problem. So the comprehensive benefit plan increased in that 4 years. The total cost increased by 32%. Some of that was driven by the fact that the city was hiring, so there were more employees, so the cost is going to go up because the number of people goes up. But principally, it went up because prices went up. The cost for doctor services went up only 18%, which is pretty reasonable. It's less than inflation and reflecting the increase in the number of people insured. Spending on hospitals in that 4 years went up 41%, the comprehensive benefit plan. So prices drive insurance, hospitals drive prices, and there really are not easy ways to contain this, to reduce the city's cost, which is one of the primary interests, obviously, of the members of this committee. You would have to do one of two things. Either shift more of the cost onto employees, which would be, as far as I'm concerned, unconscionable, or find a way to get prices under control. And that's basically the substance of my testimony. I'd like to comment about many things were said this morning, but One of the, I worked for 8 years, I helped run the 32BJ Health Fund. I now teach health policy at Baruch. And one of the reasons why the BJ Health Fund knows so much about what it spends on healthcare is because it gets its own claims. It receives copies of the claims that are incurred by every single member at every single institution or provider where they get their care. The city does not have its own claims because the city is not self-insured. The city is obligated to follow the rules of the insurance company because it buys insurance as opposed to being self-insured. So if the city really wanted to have the kind of analytic capability that BJ has, it would have to do two things. It would have to hire people who know something about healthcare, which OMB knows a lot about money, but I don't think they know a lot about healthcare. And secondly, they'd have to be self-insured and get their claims. And thirdly, they'd have to have a basis of comparison, which is what you guys are offering in this bill, to understand the context of those claims.
Thank you.
Okay?
All right, thank you. We'll be moving on to our next panel. And I apologize in advance for if I mispronounce any of these names. Rosemary Ciula Frisoni, Donald Affick, Aurea Mangwa, and Neil Frumkin. Proceed when you're ready. Thank you.
Okay, thank you. First, I'd like to thank the members of the Health and Hospitals Committees for this opportunity to speak to you regarding healthcare accountability and employee-related health costs. My name is Neil Frumkin, and I am the Vice President of Inter-Union Relations for the Retiree Association of DC 37. We represent over 50,000 retired workers. And I'm speaking in that capacity today. The healthcare system in the US is broken. We pay far more in healthcare costs than any other industrialized country, yet our health outcomes and life expectancy rank near the bottom of rankings of such countries. In 1960, healthcare expenses as a percentage of GDP nationally were 5%. In 2020, it was 19.7% of GDP. These costs are expected to grow by at least 5.1% through 2030. Clearly, this is not sustainable. It's more than just hospital costs, it's the whole healthcare industry. The question nationally in New York State and in New York City is how to rein in these costs. An Office of Healthcare Accountability would study employee-related health costs. It should also look at what changes are needed in our healthcare system. The Retiree Association opposes efforts to either force current or retired city workers to pay a greater share of their health care costs or reduce their access to health care services. 54 years ago, when I first began working for the City of New York, I, like others, was told I would be compensated with salary and premium-free health insurance. And later, there was a promise of a pension and continued premium-free health care. Today, you must ask yourself what must be done to honor that commitment. The answer is not to offload costs to the city workforce or retirees. Earlier, Brother Garrido of DC 37 spoke of Chicago, so I want to address that. My daughter works for the city of Chicago. Her health insurance coverage has provisions for tiered hospital coverage. When my grandson was 2 months old, she was told he needed urgent emergency open heart surgery. She was told to take him to a hospital that was not in the preferred tier for the best chance for his survival. She did, he survived, but she had to pay a hefty surcharge for taking him there. She was able to do that, but we have to ask, what about the others who are not able to bear those costs? City workers there or here should not have to fear that they will have to make the choice of whether to pay for rent, food, or for the health care they need and for themselves and their families. Imposed co-premiums, tiered coverages, increases in co-pays are not the answer. We reject an apartheid-modeled system where some can afford high-priced, high-quality health service while many cannot. Our suggestion is to stop the outrageous increases in charges for medical, hospital, medical insurance, and pharmaceutical benefits that we count on to sustain our lives. We will be willing partners in finding solutions to these problems. Thank you.
Thank you.
Hi, good morning. My name is Aura Mangual, and I am also a retiree from DC 37, Local 371. I retired in 2015. While I was at work, I hardly ever went to the doctors. And so since I retired, I have become ill. I have a cardiac issue. Now, DC 37, the Secretary Director, has spoken over there and previously. And so we have been involved in the issue of to stop the privatizing of our Medicare. We have members in retirees members from 372, Local 372. I'm not a 372 member, but I speak on their behalf because I help them with their issues. And so those retirees, especially the working ladies and gentlemen in the lunchrooms and the school crossing guards that stayed out in the cold, the winter, summer, any kind of weather, and breathing the fumes from the cars. And so those individuals that are retired from that local, they don't receive like $1,000 in pensions or even Social Security because their jobs is only a part-time position. We have retirees in our association that are suffering that impact right now because of the high cost of medical issues that they may have, and also the co-payments. I'm one that had a heart attack, all of a sudden. Never expected it. And I have a stack of bills, co-payments this high, because I don't want to pay those co-payments. They're very high for people like us on a minimal income to pay co-payments, and they have to travel far to the hospital. And sometimes you can't even take the train because the crime is very high in the city, and the senior citizens are being attacked all over the place for no apparent reason. And then they want to inflict pain on us by privatizing our Medicare, the MLC, and the OLR. And so the mayor wants to, may implement or force us into some kind of health care where we're going to have to pay each one of us $191 a month or $194 a month, plus the co-payments. And if you have to do a procedure, it's either $50, $100, and then never mind the traveling to do the procedure, because a lot of people cannot take buses, they cannot take the train because they're afraid, I'm afraid to take the subways. I was never like that. I was one of the biggest activists that DC 37 had. I never thought in my lifetime that I would be here speaking practically against them because of the issues and the fact that they want to inflict this pain and injury on us. You know, retirees, we don't have an income coming in. You know, some people I live alone, you know, with God naturally. But some people have dependents, they have a spouse, or they have a significant other, and they have to pay double the amount. Plus, you know, they have other expenses. Like my rent is $1,200. I pay my rent with my Social Security, and I live with the pension that I receive. Thank God from my job. I worked 27 years serving the city under 3 different borough presidents. And I never complained. I love my job. I didn't even want to retire because I wanted to continue working, but I left room for other people to come in and work in the city because of the services that we were going to receive. Now we find ourselves crossing the road, afraid that we're not gonna have the medical benefits that we were promised to have 55 years ago. And so when Mr. Garrido spoke today and he threw all this $1 billion number here, $1 trillion, and the cost of this, is he thinking about the cost that it's going to cost us? We don't have any other income coming in. We're set for life. Some people retired 15, 20 years ago. They don't receive any kind of money. Some of the ladies that I have helped going to the hospital and being an interpreter, they receive $446 a month for pension and less than $1,000 in Social Security. So I implore you that in whatever bill you will implement, because I know that you serve the people of New York in your particular district, think of the retirees and the retirees that are coming and the active members, that they don't earn all this money to be paid all this high cost of medication, hospitals, and whatever else comes with it. Thank you, and please excuse me if I get a little nervous, but
thank you. Thank you. I appreciate your
I'm
time.
speaking to you from my soul as a person, and for the people that are silent and they cannot speak, or they're afraid to come, you know. I stopped being afraid because I got sick and I need help. I need my medical care. And I think I work and I pay my dues. Thank you.
Thank you for your time. Thank you for working for the city of New York.
And thank you for your services.
Thank you.
All right, thank you. We're going to be moving on to our last in-person panel. I'm going to hear from Kevin Mora, Leslie Moran, Kevin Elkins, and Rosa, and I'm sorry I was not able to understand your last name, so if there's a Rosa in the room, please.
You can start. Thanks.
Good afternoon, council members. Thank you for having me here. My name is Kevin Mora. I'm a New York City resident and the co-founder of Power to the Patients, a nonprofit advocacy group that fights for a more affordable, equitable, and honest healthcare system across the country. Our focused efforts include raising awareness that prices are now a patient's right, thanks to the hospital price transparency rule. We also support further legislations in cities and states around the country, such as Bill 844 for New York City. As an organization, we also remind the federal government of their duty to enforce their own price transparency laws, which they have unfortunately wholly and shamefully unenforced And at the federal level, it's worth pointing out that the roughly 4,600 hospitals that are still not complying with the federal transparency rule after 2 years have only fined 2 of them. It's an unfortunate and pathetic performance by both HHS and CMS, and this reality fully supports the reason accountability is needed here at the local level in New York City. Maybe the federal regulators are overburdened or inadequately prepared, or let's keep in mind it's a trillion-dollar industry, potentially somehow they are compromised. I also don't want to be indistinct because the gentleman from the Greater Hospital Association kept pointing out that the latest reports from CMS were sparkling for hospital price transparency. There was a disclaimer with that report, and I quote, "The results cannot be used to determine compliance with respect to every regulatory requirement, which often necessitates a more detailed analysis and direct interaction with the hospital as occurs during a comprehensive compliance review." In short, the report is not a detailed, comprehensive compliance review, and it should not be weighed as such. I think it's also an interesting litmus test when the same gentleman from the Greater Hospital Association was asked if he knew the prices for COVID testing, I believe at Montefiore. He said no, he hadn't memorized all the costs at all the hospitals. If transparency had been adopted here in New York City, he easily could have pointed out how to find that information out. I trust it is not easy to discern. Over the last 2 years, Power to the Patients has worked alongside patients, unions, other advocacy groups, and various publications to fight for transparency in healthcare. We have created several PSAs and high-level speaking opportunity with well-known individuals who wholeheartedly believe in this mission to create transparency in healthcare. This includes Bronx rapper Fat Joe, Greenwich Village resident Susan Sarandon, famed photographer and Tribeca resident Martin Scholler, Brooklyn-based Grammy-nominated singer Valerie June, and several Broadway theater stars, including Academy Award-nominated Cynthia Erivo. We also work with the world-famous street artist Shepard Fairey, whose art can be seen in museums, galleries, and communities around the world, including here in New York City, where his mural for price transparency has been painted in the Bronx, Queens, and Brooklyn by the Tats Crew. Based on the latest studies by the advocacy group Patient Rights Advocate, 94% of hospitals in New York State are non-compliant with federal transparency rules, and only one of New York City's largest hospitals is compliant. New York Presbyterian, Weill Cornell, NYU Langone, NYC Health and Hospitals, Jack Weiler Interfaith Hospitals, Memorial Sloan Kettering, and Lenox Hill, to name a few, are all not compliant with the federal transparency rule. When these hospitals avoid transparency, they perpetuate a rigged system that eliminates consumerism and competition for patients and their families and stifles fair planning and negotiations for unions, employers, and the government. A healthcare system in New York City that shuns transparency is a system that is inflated, dishonest, distrusted, and works against the best interests of all the people in our city that rely on its services and procedures for health and survival. Fundamentally, this is a total betrayal of New York residents and everyone who works or visits here. If any hospitals or hospital association dares contest their non-compliance rating, I'm quite confident that Patient Rights Advocate will walk them through the findings, and I also would bet that they'd be willing to do it in a very public forum or setting. In a free market economy such as ours in the United States, competition is essential for that market to be healthy. Products and services must compete on a consumer choice based on price and/or quality. These two factors must exist or the market doesn't work. By hiding prices, the market for New York City hospitals does not and will not work. Do not get it twisted. This bill is pro-consumer.
Can you wrap it up for me, please?
Yes. I will leave you with these last statements. Without hospital prices up front, every single hospital bill is a surprise bill. Partial transparency is not transparency, much in the same way that partially paying your taxes is not adequate. If you park half your car in a legal spot and half in a crosswalk, you deserve a ticket. We need full transparency from our hospitals. Do not let the system game you. Lastly, hospitals may not have ethics when it comes to price transparency, but they have deep pockets. They have influence in an agenda for making money. They will try mightily to water this bill down. To the elected officials of New York City, all the way up to Mayor Adams, please do not be compromised on this issue. New York City needs hospital price transparency and accountability in healthcare. We support Bill 844. We must create the Office of Healthcare Accountability in New York City. Thank you.
Thank you. And which of the hospital you said that's compliant right now? That's in compliance?
The single one, I've printed out heroically scaled files of all the hospitals in New York that have been reviewed, and you can see which ones are compliant, which ones are not, and why not.
No, all right. It's many of them, because if you say one, so you want to put it on the record? Which one that's compliant?
Well, I was deferring to Patient Rights Advocate to talk on their files.
Oh, okay, no problem. So, next.
Thank you. Thank you for your patience. My name is Leslie Moran. I'm Senior Vice President of the New York Health Plan Association. We are a statewide trade organization that represents 27 health plans that provide comprehensive healthcare services to more than 8 million fully insured New Yorkers. Those are people enrolled through their employers, who buy it on their own, who are in government programs, or enrolled through the exchange. And our members also provide healthcare services to several million other New Yorkers who are covered by self-insured plans that oversee their own health benefits.
I'm sorry, could you please move closer to the microphone?
Certainly. Sorry, is that better?
Yes, thank you.
Okay, thank you. So our plans also provide services to millions of other New Yorkers who are covered by self-insured plans that oversee their own health benefits, and that includes many of the numerous unions in the city and the state. We're here today to support the Councilmember Menon's proposal to create the Office of Healthcare Accountability. On behalf of our members, we think this is a very important step forward. As per a previous speaker, excuse me, health insurance premiums are directly and inextricably tied to the underlying costs of health care. We believe that the creation of Office of Healthcare Accountability would be an important step forward, helping to increase transparency about rising costs and address the factors that contribute to the growth in healthcare spending. Our testimony highlights data that shows healthcare spending continues to rise, and that it is rising because of higher prices, especially on hospitals. All of this while utilization is actually going down. So the prices are going up, but the utilization has gone down. One way that we can start to lower costs is by giving consumers meaningful information about prices, help them shop for their care the same way that they shop for other goods. As we've talked about, the Federal Hospital Price Transparency Rule was intended to increase transparency and promote competition in the market and enable patients to compare prices. We won't debate which reports on compliance are more accurate. We would just note that there is not full compliance across the board. And of the transparent information that's out there, a lot of it is not truly transparent. It's actually pretty opaque and very difficult for consumers to understand. Another factor that contributes to increasing hospital prices is the anti-competitive behavior and contracting practices that large health systems are able to demand through market leverage. Our testimony cites a number of studies that point to the impact that this has on, that hospital consolidation has, and the ability of hospitals to exercise their market power has on prices. We've also heard from a number of our members that market-dominant hospitals often demand anti-competitive terms in their contracts. We believe this is difficult and is anti-consumer. As I said, we are here to support Councilmember Menon's legislation. We think it will play a vital role in reining in out-of-control hospital costs that exacerbate the challenge that consumers and employers and labor unions face in accessing high-quality and affordable health care. We would urge that you expand the proposed office's oversight to include the anti-competitive contract provisions that we've outlined in our testimony. The authority to examine hospital pricing and contracting practices would help address barriers to greater competition in the marketplace and also help reduce costs for New Yorkers. Again, we appreciate the opportunity to offer our comments today. Our industry remains committed to working with you and other policymakers on measures that will temper the factors that are driving increases in healthcare costs to help ensure that every New Yorker has access to high-quality, affordable healthcare. And we look forward to continuing this discussion with you. Thank you.
Thank you. Let me ask you, maybe you can clarify something for me. What are the average profits for the members, for your members?
Well, many of our members are not-for-profit plans, and I would just point out that every insurance premiums are highly regulated by the state, and they have to be actuarially supported, and health plans are required under federal and state legislation and laws to spend a certain amount of every single premium dollar directly on health care. It's called a medical loss ratio. In New York State, plans have to spend at least 82 cents of every single premium dollar on health care. And if they fail to do that, they have to refund it directly to the members or the policyholders. Plans, when you talk about profits, again, any money that a plan might make from investments is outside of what has to be spent on premium dollars.
So you're not so sure of the average profits for
I don't have the data on average profit margins, if you will, but I know many of them are on very thin margins.
executive salaries and bonuses?
We don't track that type of information.
Can you share it when you have it? Can you send it for us?
I can try and find some. Most of our plans, I will see what I can find for you, yes.
What are the reimbursement rates for hospitals? Averagely.
Pardon me?
The reimbursement rate, the rates.
They vary, I would think, by plan.
They varies? There are plans?
And I'm not sure what you mean by reimbursement rates to hospitals. It's
like if you have to reimburse a hospital for, let's pick one procedure.
I'm sorry?
Can you pick one procedure, something that you sample that everybody doing?
That would vary from plan to plan and hospital to hospital because those are negotiated between the plans and the hospitals.
Yeah. The reason I'm asking that question, because all morning I've been hearing about colonoscopy, for example, or C-section. So I just want to have a kind of clear understanding of what's going on. So
we would like to have a clear understanding too, and I think that speaks to the reason we're here is we believe that there should be greater transparency about what the hospitals are charging for these things.
Okay, so that's the reason that we're here, for transparency and trying to do, because it should not be opaque for the clients. I think you mentioned it, that for the patients that are going to get a procedure.
And health plans are very committed to transparency, and health plans have cost estimators They are required to be on the exchange in New York State. And as has been pointed out, the federal transparency rule applies to health insurers as well. But even before then, health plans were committed to having information for consumers so that they could go and get a good estimate of what their coverage would be and what their out-of-pocket responsibilities are. So plans do have cost estimators, and they encourage all of their consumers to use it to be better shoppers.
Yeah, thank you. You have any questions? So thank you so much for your time. You have something else you want to add?
I have the answer to your earlier question. The only New York City specific hospital that is compliant is the Brooklyn Medical Center in Brooklyn.
Brooklyn Medical Center in Brooklyn. Nice. So that's mean everyone else can follow.
That's right. It is possible.
Yeah. All right. So thank you for your time, and we appreciate your testimony. Thanks.
Thank you to this panel. I'm going to call up Joseph Tolano. You can proceed when you're ready.
Thank you, Chair Narcisse and Chair Schulman, and to both committees for the opportunity to testify today. My name is Joseph Tolano, and I'm the Senior Policy Manager with Primary Care Development Corporation, or PCDC. We're a nonprofit and U.S. Treasury certified CDFI, founded and located here in New York City. Our mission is to create healthier, more equitable communities by building, expanding, and strengthening access to quality primary care. Primary care remains overburdened and underinvested, with many lacking access. Although the NYC H&H network offers accessible, non-hospital-based primary care services, the uninsured or underinsured often put off seeking care for treatable illnesses like diabetes until they must seek more expensive emergency care. Nationally, primary care accounts for about 35% of healthcare services overall, but only about 5 to 7% of spending. However, primary care investment can directly improve patient outcomes and increase health equity. An increase of just one primary care provider per 10,000 people can generate 5.5% fewer hospital visits, 11% fewer emergency department visits, and 7% fewer surgeries. A study on a patient-centered medical home program in Oregon found that for every dollar investment in primary care resulted in $13 in savings on other services. For these reasons, PCDC supports the establishment of an Office of Healthcare Accountability, and specifically the provision in the legislation that requires a report that would include the operating and profit margin of major insurance providers. This data would not only fulfill the goal of a better cost transparency, but may be used to understand primary care spending by determining how private insurers are investing their profits. Additionally, the proposed commission to oversee hospital service pricing should emphasize the importance of primary care and in the role it plays in lowering overall healthcare costs and preserving hospital access for those in need of hospital-specific services. Including a focus on primary care will help the commission achieve its goal of promoting financial stability for hospitals and lowering overall costs. Finally, I want to draw the Council's attention to a series of reports and searchable dashboard relating to primary care access in every City Council district, which was created by PCDC with generous and much appreciated support from this Council. Unfortunately, our research revealed that communities with less access to primary care before the pandemic experienced more COVID-related illness and deaths than communities with better access. Our written testimony includes more details and links to the dashboard, and we'd be happy to provide additional information. We urge policymakers to ensure that spending on primary care and preventative services meets the demands of the communities that they serve, so people can live healthier lives and so that they need a hospital only for the complex care that they are best suited to provide. We encourage the members of the Council to reach out anytime for more information about primary care in their districts. Thank you for your time, and I'd be happy to answer any questions.
Thank you for your testimony.
Thank you.
Okay, I'm going to call a few names in person, and if they're not present, then we're going to move on to virtual panelists. Rosemary Ciula Frassoni, Donald Affick, Kevin Elkins, and Rosa Rail. Okay, and at this time, if there's anyone in the room who has not testified but would like to do so, please fill out an appearance card. All right, seeing no one, we will move on to virtual panels. Our first virtual panel will be Elizabeth Benjamin, Ilaria Santangelo, and Meta Ghosh. Elizabeth, you'll be first, and please wait for the Sergeant at Arms to call time before you begin your testimony.
You may begin. Elizabeth.
Hi, sorry. I'm so shocked. Finally be up. Yay, hi. How are you all? It's been a long morning, I would imagine, and now afternoon. So if it's long for me, it's even longer for you all. Thank you for being willing to accept my testimony virtually. I was also testifying at another hearing this afternoon and managed to get that done. So it was hard to be in two places at once. So thank you again for your patience and hanging in there on this really important issue. I work at the Community Service Society of New York. We've been around for over 175 years, trying to improve the lives of working New Yorkers. And one of our sort of domains is healthcare, and that's the division I head up. And our healthcare division helps around 100,000 New Yorkers either enroll in health insurance or deal with other access to care issues. One of the things we've seen in the last couple of years by running our data is we have noticed a 64% increase in what we call cost of care cases, but really you might think of as medical debt cases. So this is where people are having problems getting claims submitted, accessing care, asking for hospital financial assistance, you name it. We've also done a lot of research on hospitals suing patients. We've actually looked at every single hospital in the state of New York in all 62 county courts and identified that the hospitals have sued over 54,000 patients during the 5-year span of time between 2015 and 2020. That's a lot of people that got sued. And we were disappointed that so many people were being sued because when we did a random poll of those cases, we found that the people who were being sued lived in majority minority zip codes often and low income communities almost all the time. And this is completely consistent with the big national data sets. So something is really going on there with hospital billing and medical debt and sort of just working your way through accessing care. And we know that from helping our patients directly and from our policy work that I just described. New York State has elevated healthcare prices, and our hospital prices are amongst the highest in the country. We've seen a 23% increase between 2015 and 2019 in those prices. And unfortunately, people of color and immigrants are more likely to be uninsured. So of course, they're impacted the most by those prices. This whole conversation, we have a bunch of polling data that I'm just going to skip because I know Maida also has been very patient and I want to give her a chance to speak. So I'm just going to, just mention we have polling data. 59% of New York City residents have reported cutting pills, doing all sorts of measures to kind of hoard their healthcare resources because they can't afford it. Another tranche are living in fear of being sued or having their credit ruined. So what can we do? And I guess what I would like to say is I think this bill's a really good start. And what's been sort of missing from this whole conversation about what 844 would do is
Your time expired.
no problem. Just one more minute. We really support this bill and why. So what everybody's been talking about is you go onto each hospital's website. Well, there's 40 in New York City. No patient can do that. What 844 would do is set up a central website that everyone could go to and then do apples to apples comparison, much like the New York State of Health marketplace. That's what consumers need. They need a price comparison tool between hospitals. It's not helpful. I mean, Councilmember Menon was so, articulate and talking about like, oh, I too have gone through all the hospitals, individual, price transparency things. But even if we had those 300 shoppable events that David Rich was talking about in a central database where you could pull down like 3 or 4 hospitals at once in your neighborhood and do apples to apples comparison, what a boon that would be to the patients we serve. And I think that's what we've been missing. The thing that I would also add to 844, which is not currently in, that we'd love to see, is to also have quality measures be compared across hospitals. And of course, access to hospital financial assistance, which is something that did come up about the community benefits. It's a major component of community benefit obligation, is how much financial assistance are these hospitals actually supplying. So I will stop. I'm happy to take questions if anybody's left, but I also understand it's been a long day.
Thank you for your testimony. Any question?
Thank you. We'll be moving on to Ilaria Santangelo. Please wait for the Sergeant at Arms to call time before you begin your testimony.
You may begin.
Good afternoon, New York City Council members. Thank you for the opportunity to testify today about the need to create an Office of Healthcare Accountability in New York City. My name is Ilaria Santangelo, and I'm the Director of Research at PatientRightsAdvocate.org, a nonprofit, nonpartisan organization seeking real prices, real choices, and a functional marketplace in healthcare. I led the team that created the recent Hospital Price Transparency Compliance Report, which found that only 24.5% of hospitals nationwide were fully complying with every regulation in the federal price transparency rule, in effect now over 2 years. New York hospitals fared worse at 6%, with major New York City health systems such as New York Presbyterian, New York Health and Hospitals Corporation, Northwell Health, Mount Sinai, and NYU Langone failing to fully comply. It is also important to note that CMS published their report and claims, which I quote, "The results cannot be used to determine compliance with respect to every regulatory requirement, which often necessitates a more detailed analysis in direct interaction with the hospital as occurs during a comprehensive compliance review." CMS makes it clear their report is not a detailed, comprehensive compliance review. Here at PRA, we are transparent about our methodology, which CMS is not. We believe that partial compliance is non-compliance. It's also important to note that the Office of the Inspector General is investigating CMS on their enforcement of this rule. As you know, by law, hospitals must post all prices clearly and completely by payer and plan, including the cash prices. Despite what the hospitals say, this is easy. They want you to think it's hard, and the only groups opposed to this transparency are from the hospitals and insurance companies. Only when consumers can compare prices and see, for instance, that an MRI can cost $300 or $3,000 can they make good purchasing decisions. Fully compliant transparency would unleash competition, level out price variations, and lower healthcare costs for all patients, employers, unions, and workers. I also think it's worth mentioning, and let's not sugarcoat this, estimates do not work. They provide no accountability, and the estimates hospitals are actually providing patients disclaim that it's not going to be the final price, and they make patients check a box to make sure that they agree. We don't tolerate this elsewhere. Let's stop tolerating it in healthcare. Please vote in favor of this bill. New Yorkers need this. Double down on the federal law and let New York take the lead in revolutionizing healthcare in our country, holding New York City hospitals accountable and lowering healthcare costs for all New Yorkers. Thank you.
Thank you for keeping with the time. Thank you for your testimony.
Thank you. We'll be moving on to Meta Ghosh. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Good afternoon. My name is Meta Ghosh, and I'm the Health Policy Coordinator at CACF, the Coalition for Asian American Children and Families. Thank you very much to Chair Schulman and Chair Narcisse for holding this hearing and providing this opportunity to testify. Founded in 1986, CACF is the nation's only Pan-Asian children families advocacy organization and leads the fight for improved and equitable policy systems, funding, and services to support those in need. CACF is in support of Councilmember Menon's Intro Bill 844 that would establish an Office of Healthcare Accountability. We see a major need for cost transparency of New York City hospitals. Our hope with this bill is that language access will be centered in its implementation. As the bill plans to create a publicly accessible website that provides information on the cost of hospital procedures and summarizes cost transparency of each hospital, it is important that this site would also be available in a variety of languages so our limited English proficient or LEP patients are able to access it as well. We also hope that cost transparency would also include the cost related to hospitals' usage of translation interpretation services for LEP patients. Nearly 19 million people reside in the New York City metropolitan area, and over 800 different languages are spoken. Because of New York City's linguistic diversity, it is incredibly important to ensure language access. Language barriers are a huge obstacle faced by many folks in immigrant communities. Language barriers can prevent folks from accessing vital services like healthcare. Despite there being 76 language access policies targeting healthcare settings in New York State, we have found that many LEP patients still report facing difficulties like being unable to find an interpreter that speaks their dialect or being unable to fill out paperwork because a translated version in their language does not exist. While hospitals spend considerable amounts on language services, our research has found that these services often do not meet the needs of LEP patients. There is a need for more accountability and transparency around usage of funding by hospitals towards language services so that language access in healthcare settings can improve. We hope that language access can be prioritized in the creation of an Office of Healthcare Accountability. Thank you very much for your time.
Thank you for your testimony.
Thank you very much. We're going to be moving on to our next virtual panel. We're going to have Dr. Vikas Saini, Lola Simpson, and Maria Vieira. Please wait for the Sergeant at Arms to call time. We'll start with Dr. Saini.
You may begin.
Hi, thank you. My name is Vikas Saini, and I'm pleased to be here to support this proposed legislation. I'm president of the Lown Institute, which is a nonpartisan think tank in Boston. We're committed to the creation of a healthcare system that's socially responsible and that works for everyone. Now, we think American Health Roads is at a crossroads. When nonprofit hospitals were first established over a century ago, there was an implicit social contract. Communities would invest in hospitals by foregoing tax dollars, and in exchange, hospitals would provide charity care and promote community health. Now, over these 100 years, American healthcare has increasingly become a money-driven system, and our research has found that now nonprofit hospitals too often, do not hold up their end of the bargain. The Lown Institute publishes many metrics of hospital social responsibility. The one called Fair Share compares a hospital spending to direct community health needs and compares that to the tax breaks that hospitals receive. Nationwide, the majority of nonprofit health systems fall short. Last year, we found they took $18 billion more in tax breaks than they spent on charity care. We recently conducted, on behalf of 32BJ, a more detailed study and reported on New York City's fair share deficits. We found that 9 of the 21 nonprofit hospitals, including many of the largest and most prestigious, spent less on their communities than they received in tax breaks, resulting in a deficit of $727 million for New York City taxpayers in 2019. Now, $727 million would go a long way to addressing a lot of community health needs in mental health, for example, HIV care, and housing stability. In fact, it would be enough to pay for 7,000 social workers, 30,000 annual doses of HIV drugs, and thousands of affordable homes. The wide gap between health needs and community investment reflects a fundamental disconnect between the intent of our laws and their implementation. And I would say that goes for the IRS rules as well. Although the Affordable Care Act requires hospitals to assess their community needs, there is no requirement that they link their spending to those needs. The fair share deficits we're reporting are just one of many examples of serious systemic problems in American healthcare. Too little transparency and no accountability. We've been hearing about it for prices. The same is true for community benefit spending. New York now has an opportunity to lead the nation in correcting these deficiencies, and so we support the creation of an Office of Healthcare Accountability. We support provisions that would require full and accurate disclosures of hospitals' multiple property parcels under many different names to improve estimates. Thank you. Of the tax breaks they enjoy. We also support provisions that would require detailed disclosures of program implementation to connect hospitals' community benefits spending to specific, well-adjudicated and pressing needs of New Yorkers. Finally, American healthcare needs real help in transitioning away from a money-minded system that it's become to one that's affordable, effective, and accountable to the communities it serves. I have plenty of responses to questions throughout the day. I've been listening since 10 a.m., including the percent of charity care, the nature of what should and shouldn't be allowed for community benefit spending, and I'm happy to answer any questions you have. Thank you for your attention.
Thank you for your testimony. Any questions, colleagues? No. Thank you so much.
Thank you. We'll be moving on to Lola Simpson. Please wait for the Sergeant at Arms to call time before you begin your testimony.
You may begin.
Thank you. Good afternoon, everyone. Good afternoon, Chair Narcisse and Schulman and members of the committee. My name is Lola Simpson, and I'm the CEO for AIR-NYC. I'm speaking today on Bill 844 in support of vulnerable New Yorkers, whom AIR-NYC serves. For more than 20 years, AIR-NYC, a small community-based organization now located in the South Bronx, has been serving individuals and families citywide using a community health worker CHW model. We strive to improve equity in healthcare access and social care for underserved people of all ages, races, ethnicities, faiths, who bear the highest burdens of poverty and chronic disease, including asthma, diabetes, COPD, hypertension, and high-risk pregnancy. Last year, we reached more than 30,000 Bronx residents with education and resources and provided personalized support to more than 2,000 New Yorkers, helping them to navigate the healthcare insurance and social care systems, while providing connections to and coordination of care, health coaching, support for chronic disease management, and social care screening and referrals. AIR-NYC works with residents primarily comprised of Black and Hispanic New Yorkers who are already marginalized by structural racism and barriers. The lack of transparency about costs associated with hospital procedures disproportionately impacts the most vulnerable New Yorkers, including AIR-NYC participants. Therefore, we are strongly in support of this bill to establish an Office of Healthcare Accountability that will provide transparency in costs associated with hospital procedures and report on the operating and profit margin of major insurance providers. Further, our CHWs often find that individuals and families with whom they are working to connect to care, especially those with multiple chronic diseases requiring hospitalization, specialty care referrals, and medical procedures, forego or postpone recommended care. And when asked why, some individuals express concern about costs. So, establishing an Office of Accountability would offer transparency in the cost of hospital procedures and enable our CHWs to help community residents make informed decisions about their care. AIR believes that a resource disclosing information about hospital performance in meeting the needs of New York City underserved communities, including many residents we serve, would be useful in motivating people to pursue needed care in an appropriate setting. This would be particularly useful for undocumented or uninsured New Yorkers who rely on accessing charity care services. A reliable database of where and how to access hospital charity care services would be extremely useful. In summary, Bill 84 would improve health equity for vulnerable New Yorkers. Thank you very much for this opportunity to speak on behalf of vulnerable New Yorkers from across the city.
Thank you for your testimony.
Thank you. We'll be moving on to Maria Vieira. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Thank you. Good afternoon, Chair Schulman, Chair Narcisse, members of the Health Committee. My name is Maria Vieira. I'm VP of Community Affairs at Riseboro Community Partnership, a local development corporation born in Bushwick, Brooklyn. For the past 50 years, Riseboro has developed over 4,000 units of affordable housing and has provided critical social services for families and individuals from cradle to grave. Riseboro employs close to 1,300 individuals, many of whom are human service workers, which, by the way, we're fighting for their just pay. We believe it's important that the council understands how rising healthcare costs are impacting New York City employers like Riseboro. For many employers that purchase insured products, they may experience rising insurance costs. But from our analysis, we believe these are largely driven by hospital price increases. Out of control hospital prices drive down wages as they encroach on our fringe rates. Also, there is significant barrier to accessing affordable health care for working people. According to the report by 32 VJ Health Fund, if New York City's hospital pricing and spending patterns match the rest of the state, it could be overpaying by as much as $2 billion annually on hospital costs. We believe the city is overspending on healthcare costs for its employees by $2 billion a year, which cuts into the funding for affordable housing and critical social services that organizations like Riseboro provide. Intro 844 will establish an office that will scrutinize and reveal hospital pricing influential variables. If and when a $2 billion overspending is realized, our hope is that the funds are reinvested in healthcare, affordable housing, and social services in communities slighted by disinvestment, like the neighborhoods where most of our employees reside and our services are provided. Our vision at Riseboro is to build a city where your zip code does not determine your health outcomes, housing stability, or economic power. Intro 844 can be a step to help determine those outcomes. Thank you for the opportunity to speak.
Thank you for your testimony.
Thank you very much. We'll be moving on to our last virtual panel. We'll be hearing from David Seltz and Christian Deacon. David, we'll start with you. Please wait for the Sergeant at Arms to call time before you begin your testimony.
You may begin.
Good afternoon, esteemed members of this committee. It is truly an honor to testify here before you today. This has just been an incredible hearing and just really reflective of the importance of this issue. My name is David Seltz. I am the Executive Director of the Massachusetts Health Policy Commission, or the HPC, as we like to call it. The HPC is an independent state agency that was charged with monitoring healthcare spending and cost trends in Massachusetts with a stated goal of a more transparent, accountable, equitable healthcare system that delivers better care, better health at a lower cost for all. Given some of the similarities between our mission and work and that of the proposed Office of Healthcare Accountability in this proposal, I hope to share a few final thoughts today based on our experience over the past 10 years to help inform your deliberation. In short, we have found that the establishment of a dedicated government office focused on healthcare costs and enhancing transparency to be a tremendous benefit to policymakers, to workers, to patients, and to the general public. I would strongly encourage your close consideration of this proposal for the people of New York City. A bit of background on the HPC. The HPC was established 10 years ago as part of comprehensive legislation, really focused on healthcare cost containment. Our purview is the entire healthcare system, so all providers and health plans, but we do not regulate pricing. Our tools really are public reporting, public accountability, setting public measurable goals for improvement, and providing data-driven policy recommendations. Like New York City, Boston is home to some of the most prestigious hospitals in the world and is a hub for biomedical innovation. We are also a very expensive healthcare state. In 2009, Massachusetts was the #1 most expensive state in the country on per-person healthcare spending. This high level of healthcare costs, combined with high annual increases, resulted in an unsustainable burden on our state and municipal governments, on our businesses, especially small businesses, and of course on families and individuals, and especially families and individuals of color and low income. In response to this challenge, Massachusetts created the HPC and set an annual target for reducing healthcare spending growth. So how have we done? In the past 10 years, Massachusetts spending growth has been below the comparable US average every single year. A national study found that Massachusetts had the second lowest rate of growth from 2013 to 2019, and the result has been billions saved, billions in building our economy, growing jobs, growing wages. And now today, Massachusetts is no longer the most expensive state. We are #3, surpassed by Alaska and New York. So in closing, I would just like to encourage the committee's consideration of this proposal And I will stand ready as a resource as you move forward with your deliberations. It's really been an honor. Thank you so much.
Thank you for your testimony. 1 second. I'm passing on to my...
Hi, I'm Chair Lynn Schulman. I wanted to ask a question. Do you have anything in writing that shows the progress that you've made that you could send to the council? We'd really appreciate that. That would be very helpful.
Absolutely, I'd be happy to. Thank you.
Any question? Any more? Okay. Thank you.
Thank you. We're going to be moving on to Kristen Deacon. Please wait for the Sergeant at Arms to call time before you begin your testimony.
You may begin.
Thank you. Good afternoon, honorable council members. Thank you for the opportunity to speak in favor of 844 today. I currently work with self-funded healthcare organizations in New York City and across the country. And I'm also the former administrator of the State Health Benefits Program for the state of New Jersey, where we represented 820,000 public sector workers. We know that hospitals are essential to the US healthcare system and the communities that they serve. But despite this vital role in our communities, the role that some of these hospitals in our economy has shifted in destructive ways. Maximization of revenue rather than the improvement of health is absolutely the standard operating procedure, and it's often cloaked by the claim of no margin, no mission. Many of those testifying before you here today, including myself, have been tasked with managing billions and billions of dollars of worker wages, taxpayer dollars, and employer funds. The truth remains that you can't manage what you don't measure, and you cannot fix what you will not face. Hospital price transparency, and indeed more healthcare industry transparency, such as the type found in this bill, is really foundational to begin to fixing the process. For the first time, healthcare purchasers and consumers will begin to see exactly how and why their money is spent where it is. How was that new glass atrium paid for? Who's paying that multi-million-dollar executive salary? The gentleman from Greater New York Hospital Association made comments regarding the profit margins of insurance carriers. And perhaps this group, and suggesting that this group would be better served looking at them when trying to solve this problem. The issue, with all due respect, is that when we as self-funded purchasers sit across the table from our carriers and third-party administrators, we are told that hospital prices and anti-competitive contract terms and requirements are the cause of those price increases that occur year over year. So which is it? This is why we need to see the numbers and make informed decisions instead of guessing and pointing fingers. The narrative that it's too complex and that we won't understand the data or we could misinterpret the data, it's just frankly a transparent attempt, pardon the pun, to keep the system opaque and shrouded from the disinfectant of sunshine that is so sorely needed. Another question was asked that I wanted to address. The Honorable Councilwoman asked how the same service, their cost could vary so widely from hospital to hospital for the same service. But to take it further, how can the same procedure at the same hospital vary in price depending upon the symbol of your insurance card or whether even you have an insurance card?
Your time expired.
We know that. Finally, I want to address two final points raised by Greater Hospital of New York, and that is that this bill would be unnecessary because hospitals are already compliant and that further regulatory burden is a cost too high. Even though I do not believe this to be the case, if all hospitals were fully compliant, what this bill does is put all of that information into a more usable format for consumers and purchasers. Moreover, when talking about resources and labor challenges, I want to highlight a quote that a CEO from one of the largest systems, nonprofit, non-compliant, and member of Greater New York made recently when talking about labor challenges. He says, "We're going to come out of this winning. Even if we do have a recession, it doesn't mean that people don't get sick. In fact, people's problems are going to increase. Our business will not slow down if we have a recession. It will increase. And the healthcare sector, even in a recession, the need for hospital services will increase. Leadership to me is about having a positive disposition, basically saying that whatever happens to you, you're going to win, unquote. What does winning look like to hardworking New Yorkers that can't afford care? What does winning look like to the retirees that are forced to come here to you today because hospitals insist on winning at the expense of our citizens? We're not asking for anything more than transparency so that we can begin to have informed conversations about how to achieve an equitable and just healthcare system where the patients and the people have a chance to be the winners. Thank you.
Thank you for your testimony, but I have one question. There's something you just stated that you can have the same surgery with no extra complication, but different prices. Am I hearing that right?
Absolutely. You can go to the same hospital, have the same procedure, and depending upon the insignia or the symbol on your insurance card, whichever payer, or even if you're uninsured, the rate that you are paying can be very different.
Interesting.
At the same exact facility.
Yeah, I need facts on that one, because I thought if you have complication, that can justify why the procedure is different. But if it has to do with the insurance card, well, that's a question.
Yes.
Thank you. Hold on one second. And any question from you? Okay, no more questions. Thank you for your testimony.
Thank you.
Now I'm going to turn it over to Council Member Menon. Oh, you have, okay. Hold on one second. Let's go backward.
Thank you. At this time, I'm going to read the names of people who registered to testify virtually who were not available when we first called their names. Maureen Hensley Quinn, Donald Affick, and Victoria Veltri. No? Okay. And then at this time, if there's anyone else who would like to testify virtually who has not had their name called, please indicate so using the Zoom raise hand function. Seeing none, turning it back to the chair.
Thank you. Now I'm turning it over to my colleague, Council Member Julie Menon.
Thank you so much. I really want to thank you, Chair Narcisse and Chair Schulman, for this fantastic hearing. I thought we heard so much compelling testimony from so many different stakeholders about why it is important that the Council acts on the Healthcare Accountability and Consumer Protection Act and passes this important piece of legislation. So really want to thank you both. I do want to mention one thing, though, on the record. There was a few people who testified and talked about tiering, and I just want to, for the record, clarify this bill has absolutely nothing to do with tiering. It doesn't say anything about tiering. It doesn't relate to tiering, and on the contrary, knowing more about price creates a healthier and more competitive market for both individuals and for institutions. And counter to some of the testimony we heard about tiering, without more information, we can't drive down the prices, and we can't really make sure that we are focusing on creating long-term affordable coverage that is accessible for all. So I just wanted to make sure I corrected that misimpression directly on the record, and we really look forward to continuing the dialogue on this. Thank you so much.
Now, Chair Schulman, any closing remark?
I want to second what Councilmember Julie Menon said. It was very compelling testimony today. We got a lot of information, heard from a lot of different parties, including people outside the state. And, you know, we're very appreciative of that. And it just shows how great this bill is going to be, and looking forward to reducing the costs of health care for New Yorkers and making sure that everyone, no matter what zip code they live in, has access to affordable health care. Thank you.
I just want to say thank you. Thank you for everyone that come out to testify. I'm Council Member Mercedes Narcisse and Chair on Committee on Hospitals. But without all the staff that doing the work, it would not be possible. So I want to take a time to say thank you to Christopher Pepe, Senior Legislative Counsel, Sarah Solker for your time, and thank you, Legislative Council, and Manu Budd, Legislative Policy Analyst, Daniel Clint for Finance Analyst, Brooke Fryer, Senior Data Scientist, Committee on Hospital Staff, Manu Budd, that's not here today, Legislative Policy Analyst, and Grillian Francisco, the Unit Head, Finance Division, and James Hu, Data Scientist, and everyone else that participate that make it possible. So today we had a chance to open the process, open eyes, and a lot of question, a lot of testimony. So I am so much appreciative for my colleague, Julie Menon, that keep on pushing to make sure that we have transparency. We're not here to regulate. We are here for transparency because we feel in New York City we should provide quality of healthcare in every angle of our city. It should not be for one group, not the others, and we still focus on preventive care. As a nurse myself, and we know the difference that can make, and we want folks to be able to go to hospital on a regular basis if they have to, and they have to go for their preventive care. It's cost effective, and we should continue doing that. Health is wealth. So I thank you everyone for keeping up with us since 10 o'clock in the morning. Say we're about to close it up. So if anything else, I'm gonna say thank you everyone, and we're gonna sign out.